This is the California State Senate.
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 Este es el Senado Estatal de California.
This is the California State Senate. This is the California State Senate.
This is the California State Senate.
Esta es el Senado Estatal de California.
This is the California State Senate.
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 Este es el Senado Estatal de California.
This is the California State Senate.
This is the California State Senate.
This is the California State Senate.
Esta es el Senado Estatal de California.
This is the California State Senate.
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 Este es el Senado Estatal de California.
This is the California State Senate.
This is the California State Senate.
This is the California State Senate.
Esta es el Senado Estatal de California.
This is the California State Senate.
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 Este es el Senado Estatal de California.
This is the California State Senate.
This is the California State Senate.
This is the California State Senate.
Esta es el Senado Estatal de California.
This is the California State Senate.
This is the California State Senate.
This is the California State Senate.
Well, good morning, everybody. Good. There was kind of a delayed response there. I figured maybe there was nobody in the room. So, I mean, beautiful day, and I see a lot of obviously friendly and familiar faces from individuals from Sacramento and throughout the whole state. So, I'd like to just welcome everybody to Southern California. Here in Los Angeles, but we're going to have the Senate Health Committee oversight hearing. Today's November 18th, the future of the California Children's Service Program here at the California Endowment. I'd like to personally, if anybody's here from the Endowment, to thank them for allowing us to have this hearing here. We have quite a few speakers. They are time limited, and then we will be having some public comment at the end. Unfortunately, the chair of the Assembly Health Committee was unable to schedule it to be here today. But as you know, we just recently had the signature of the extension, which I think is a very, very important part of the issue that at hand. As you know, I have a piece of legislation, which is a 2-year bill. We're going to hear about the CCS program today. But more importantly, figure out how we can find out a resolution with regard to this most vulnerable portion of the population. So with me today is Senator Pan. I don't know if Senator Pan wanted to make any opening comments before we get started at all. Yeah, why don't you go ahead and make some comments if you like.
Well, thank you, and I want to thank Senator Hernandez for holding this hearing on CCS. So obviously CCS is something that's very dear to me as a pediatrician and actually as a CCS provider myself. In fact, most of the patients I took care of as a faculty member at the University of California, Davis were children with special healthcare needs, and many of them were on the CCS program. And certainly in my career, I've devoted my career to studying quality improvement, systems of care for children with special healthcare needs, managed care as well. Fortunate to train with some of the leaders in the field, people like Dr. Jim Perrin, Dr. Charlie Homer, Dr. Judith Palfrey, Tom Inouye. And also, even myself was appointed to a federal task force on access to specialty care from the Bureau of Maternal Child Health federally, as well as serving leadership positions in my professional associations like the American Academy of Pediatrics and representing UC Davis Children's Hospital on organizations related to children with special needs. So certainly this is an area that I developed a considerable body of knowledge and expertise during my time both in training as a primary care research fellow and also subsequently as a faculty member at UC Davis. So certainly this is an area that I'm certainly very interested in, but also I think as a state we're very interested in being sure that these children get the best quality of care. And in fact, there's a significant body of research about what the best quality of care is. Anything from, including medical home models, the innovations developed for example, cystic fibrosis care, where I think parents got together and worked with healthcare systems across the country and reduced disparities in care outcomes for cystic fibrosis. And I think it's basically held up as a national model for how we should approach disease management. And certainly, I think we need to look at the evidence and take evidence-based approaches to ensure that we have quality of care. And that should really be the goal that we're pursuing. So as we're trying to look at how do we reform CCS, and CCS is a long-standing program to provide access to specialty care, we definitely need to look at what the evidence shows in terms of how do we reform this system of care. And certainly I, in my career, have always advocated improvements in the CCS program. I think many of you know that I have urged people to say, let's not just leave the program as it is, but we need to make improvements. But those improvements need to be evidence-based that prove that they're going to lead to improved outcomes. I think as Senator Hernandez said, this is the most vulnerable populations. These are children, in my mind, these are children who have special needs. And we need to do more to be sure that they get quality of care. And there is research and evidence out there that demonstrates what needs to be done. So we need to be sure that as we're looking at reforms in CCS, that informs what we do. And so my challenge to people who are going to be testifying and in the further work ahead is also to bring up the evidence. What is the evidence that underlines what you're proposing? Where's the proof that it will provide improved quality of care than the one we have now? And I think that is what we should be looking at first and foremost as we move forward. So again, I want to thank you, Senator Hernandez, for your leadership and for holding this hearing, and I look forward to hearing the testimony today. Thank you.
All right, well, let's go ahead and get started with item number 1. It's the overview of the California Children's Services Program. This first speaker is going to be up is Mary Doyle, MD, Associate Medical Director, California Children's Services, Los Angeles County. And the second individual is Danelle Kenworth, parent of a child enrolled in CCS. So we can allow Dr. Doyle to come up and please proceed. Thank you and welcome.
All right, thank you. Good morning, esteemed members of the Senate Committee and audience participants. Thank you for the opportunity to address you today about the California Children's Services Program. My name is Dr. Mary Doyle, and I am a pediatrician and the Associate Medical Director for Los Angeles County, California Children's Services. Closer to me, thank you. In my brief time with you today, I will give you a general overview of the program as background needed to address the questions posed to the speakers that follow. Note that the Los Angeles County Board of Supervisors has not taken a position on the CCS redesign proposal, and my purpose here is limited to such an overview, specifically what CCS does, how the program came to be, how it became and is linked to Medi-Cal, and who it serves and how. California Children's Services is a statewide program mandated by law to serve the children of California in 4 ways. First, through the case management of children with certain physically disabling conditions or chronic diseases. Examples include cancer, sickle cell disease, heart defects, and deafness. These children are assigned a nurse case manager who works with the family to develop a care plan and then authorizes and coordinates the medically necessary services needed to treat that condition. Second, CCS is responsible for finding children at risk for developing a chronic or disabling condition. CCS is the program to which children are referred to complete the diagnostic workup of suspected problems, such as those identified through the newborn hearing and metabolic screening programs, the high-risk infant follow-up program for children in neonatal intensive care units, and the congenital heart disease screening program. Physicians in hospitals may also refer children suspected of having an eligible condition, such as HIV, to complete the diagnostic workup. Third, CCS operates a system of approximately 170 outpatient rehabilitation units in schools throughout California that provide direct case management, physical and occupational therapy, durable medical equipment and nutrition evaluations, and classroom consultations for children with certain physically disabling conditions such as cerebral palsy, muscular dystrophy, juvenile rheumatoid arthritis, or amputations. Finally, CCS is the program that sets and enforces the standards for providers, multidisciplinary teams called special care centers, and hospitals who care for children with complex conditions. CCS does this through certifying or paneling providers and by site visits to ensure compliance with CCS standards. This function ensures that children with rare and complex conditions have access to providers with the expertise necessary to treat such conditions, and that the centers have sufficient numbers of such cases to maintain that expertise. The program has a rich and venerable history that I will briefly summarize so that everyone can understand the terminology that is used when talking about CCS, Medi-Cal, or managed care. CCS began when the California Crippled Children's Act was signed into law in 1927 by Governor Clement Young. The act was meant to meet the surgical needs of children with physical disabilities, which at that time were mostly the result of polio, bone infections, or fractures. The federal government followed suit in 1935 with the passage of the Social Security Act. Title V of that act appropriated funds for medical services for children with crippling conditions. States decided which conditions to cover and how to administer their programs. Over time, the initial narrow focus on orthopedic problems broadened to include many other congenital, chronic, or catastrophic conditions. In 1965, an amendment to the Social Security Act, Title 19, established Medicaid, called Medi-Cal in California, as a new funding source for medical care. In 1967, the California Code of Regulations mandated that any Medi-Cal beneficiary under the age of 21 who qualified for services as a crippled child be referred to and case managed by the Crippled Children's Program. And finally, in 1978, the Robert W. Crown California Children's Services Act, the program's name was changed, the age of handicapped beneficiaries extended to 21, and authority was given to the legislators to add conditions. Non-orthopedic conditions were added, such as cystic fibrosis and hemophilia. So how did CCS become linked to Medi-Cal managed care? In the 1980s and 90s, waivers to the federal Medicaid rules allowed prepaid arrangements for primary care of Medi-Cal beneficiaries, which was the start of managed care. Children with CCS-eligible conditions were not excluded from these contracts. In 1993, the California Strategic Plan for the Expansion of Medicaid brought managed care to more counties with mandatory enrollment regardless of the beneficiary's health status. Between 1993 and now, legislative changes were enacted to address how this plan affected children, families, and providers in the CCS program. AB 616 mandated that the Medi-Cal managed care plans maintain and follow CCS standards of care, use CCS-approved providers and hospitals, and pay enhanced rates for care of these patients. Senate Bill 1371 carved services for children in the CCS program out of Medi-Cal managed care contracts that were negotiated after August 1994. CCS services were already carved in for Marin, Napa, Santa Barbara, San Mateo, Solano, and Yolo counties. Multiple extensions to the CCS carve-out have occurred, including AB 301, authored by Dr. Pan, and most recently AB 187, signed by Governor Brown, which extends the carve-out in some counties through December 2016. And finally, how did the CCS pilots come to be? In 2010, California was granted a Section 1115 waiver to the Title 19 amendment of the Social Security Act. A waiver allows states to develop Medicaid programs that differ from the standard federal program and benefits it can authorize. It was granted to pilot projects aimed at lowering Medi-Cal costs by focusing on 4 principal patient groups who were served by Medi-Cal. One of the groups was children with special health care needs, and one of the programs that served them was CCS. Currently, I will only mention that there are 2 pilots, the San Mateo County pilot that was implemented in April 2016, and the second in San Diego that is in process. And I only mention these briefly because I see from the agenda that they will be covered in more detail by Director Kent. However, it should be noted that though these are the 2 formal pilots that have been authorized and that were funded, multiple CCS county programs have engaged in program improvement projects that have also been referred to but should not be confused with these pilots. Eligibility for CCS differs depending on the service that is being provided. In case management, the patient must be under the age of 21, reside in a California county, and have a qualifying medical condition, as well as meet a financial threshold. Those children who are full-scope Medi-Cal beneficiaries are automatically financially eligible. Those adopted with a qualifying condition, families whose adjusted gross income is less than $40,000 per year, or families who must spend at least or more than 20% of that AGI caring for the eligible condition. Those children eligible for case finding or diagnostic services, again, must be under 21 years of age, reside in a California county, and be identified through a screening program or have a high likelihood of having one of the conditions we cover. There is no financial component for participation in that service. For the medical therapy program, again, the beneficiaries must be under the age of 21, reside in a California county, and have a qualifying physically disabling condition. Again, there is no financial component for this program either. And finally, care for patients eligible for case management under the general program have their care authorized to CCS panel providers, approved facilities, or special care centers. However, any child in the state of California may receive care from a CCS panel provider or approved facility and receive the advantage of CCS verified adherence to quality standards. A word about medical eligibility. It is by specific medical conditions and has been established by legislation, but generally speaking, CCS covers those conditions that are chronic, catastrophic, congenital, or disabling. Though you will find some acute conditions in regulation that have their origins traced back to a time when what disabled children were mainly orthopedic or infectious conditions. For example, polio that caused paralysis or mastoiditis that caused deafness. The director of the state agency administering CCS was allowed to define what handicap meant, but the legislator could add conditions, and this was done 15 years ago, but such an approach makes it challenging when medical science advances and disease-changing therapies emerge and what was disabling or fatal years prior no longer is. Assessing program eligibility by specific diseases rather than by complexity of need affects care coordination and case management. Legally, CCS can only authorize services needed for the condition that conferred program eligibility. For example, CCS cannot authorize well child care or vaccinations, but it can cover care related to the CCS condition that occurs in the primary setting. Also, through its case management activities, the nurse case managers do coordinate care of the whole child among and across the systems accessed by children in CCS. So how does CCS ensure quality of care? It goes hand in hand with how CCS delivers services. First, through the provision of case management by nurses trained to coordinate care for children and families with complex needs. A care plan is developed during the call with the family or when the family is seen in the medical therapy unit, and all medically necessary care related to that condition is authorized to CCS panel providers and approved facilities. Case management also includes resource finding and referrals for services CCS cannot authorize. In carved-out counties, the Medi-Cal Managed Care Plan authorizes care not related to the eligible condition. Second, CCS ensures quality of care through the provider paneling process that requires proof of board certification and authorization of care only to such providers. Third, through the facility and special care center approval process. The State Systems of Care Division has facility and special care center standards. The facilities apply, a site visit occurs, and approval status is granted. based upon whether they have met those standards or not. And finally, the county medical directors perform monthly therapy unit reviews to ensure adherence to standards for the units to maintain their certification as outpatient rehabilitation centers. And on my final two slides, I would like to provide you with numbers that are just a snapshot of the program. Between 180 and 185,000 children in California are served in the general program and receive full case management services. Approximately 23,000 participate in our medical therapy program. An unlimited number of children are served at any of our CCS-approved facilities, which includes 13 children's hospitals, 120 NICUs, and 780 special care centers. The majority of our patients are covered by full-scope Medi-Cal, approximately 80%. The remaining 20% are referred to as straight CCS, which includes children with no insurance, partial Medi-Cal coverage, or private insurance. CCS program by the numbers. Our funding sources are a combination of federal, state, and county dollars, approximately 45%, and 10%. The medical therapy program funding is split between state and county dollars. The annual expenditure estimates for the general program are approximately $2 billion, and for the medical therapy program, $125 million. These estimates are drawn from claims data for services provided to CCS patients with the addition of what is budgeted for the administrative overhead. There are a number of factors, of course, that influence these costs, such as the rare and complex conditions that CCS covers and the need for expensive medications, equipment, therapies, or in-home services. However, it is important to point out that 92% of the funds directed to the CCS program are paid out for direct patient care. On my last slide, you will find my contact information if there are any questions that remain at the conclusion of this hearing, but I would like to thank the Senate Committee on Health Oversight for convening this important hearing and for the opportunity to address you today. Thank you.
Okay, thank you. If you don't mind, I'll have you stay up here because we're going to ask questions of the panelists after the panelists spoke. We're going to now move on to Donnell Kenworthy, parent of a child enrolled in the CCS program. Good morning and welcome.
Yes. Hello, and thank you for the privilege of letting me share with you what CCS has meant to my family, the Kenworthy family. I'm Donnell, and there's some pictures up there of my son, DJ. 20 years ago, when DJ was born, we thought we had prepared ourselves for the birth of our fifth child, born when my husband and I were pastoring a small church on the North Coast in Humboldt County. Minutes after his birth, we realized that DJ had severe complications, and a transport team was called from UC San Francisco. My husband and I explained to the discharge nurse that we could not cover these costs, and it was a frantic time, and decisions for DJ's care were coming fast and furious, and we felt like we were in free fall. The nurse assured us that there were safety nets in place for children like DJ. Within 24 hours, DJ was diagnosed with heart conditions requiring multiple surgeries, including open heart surgery. DJ stayed at UCSF for 2 months. I did not know that you could actually live in the hospital, but night after night, they gave me a bed to stay close to him as he fought for his life. CCS provided housing, vouchers for food, coordination, and payment for his complicated care. We were overjoyed when DJ got to come home, but in the months following, DJ faced more complications and more hospitalizations. He needed a gastrostomy tube placed so that we could feed him. A CCS panel doctor at UCSF did the surgery. Just prior to his first birthday, his local doctors were stymied as DJ began turning blue 4 and 5 times a day, gasping for oxygen. He needed the specialty care of a CCS panel pulmonologist in San Francisco, and he spent 3 months in ICU where he was diagnosed with severe malacia, and he received a tracheostomy and a vent to help him breathe. As this drama played out in DJ's life, CCS coordinated services at home for 16 hours a day nursing care we were going to need to bring him home. At home, his bedroom had been outfitted like a mini ICU for all of his needs. And he was an active little guy with a trach and a vent bouncing around his crib, causing all of his nurses to lament, "I thought a baby this sick would just lie there." DJ amazed everyone when he healed enough to have this trach and vent removed just before his 2nd birthday, but he continued to have medical challenges. Our safety net, CCS, continued to support us as we moved from Humboldt County to Yolo County. We no longer had a 5-hour drive or a medical flight or the care that DJ needed. Now I could drive him 20 minutes to a CCS paneled provider, like his pulmonologist, his gastroenterologist, his cardiologist, and he had a nutrition and respiratory therapist through a specialty care unit and his primary care. We were grateful for this support when DJ had his 2nd open heart surgery at age 5. Sometimes we did feel that things could have gone better with CCS. I've often wished that we as parents could provide more frequent feedbacks through a survey process, not unlike what is done in medical care these days. Sometimes we felt adrift when services or medications were denied. Transitioning out of CCS is looming as DJ is turning 21 soon, and I feel that CCS could possibly do a better job of preparing and supporting families and identifying and securing providers in their own communities. But CCS has been great to us. Recently, DJ had pneumonia. When insurance denied the medication ordered by his CCS panel pulmonologist, I was able to call his care coordinator, Ellen, who knows DJ's needs, who knows him, and made sure that he received timely access to the medication that he needed. CCS has been and continues to be a safety net, alleviating fear and anxiety, helping our family to heal, and literally saving DJ's life. He is a part of our community. He is an advocate for those with disabilities. He's a part of his sister's lives and his 10 nieces and nephews, and I'm grateful for that. Thank you.
Thank you. Any questions from Dr. Pan?
Yes, actually, thank you. Thanks very much. So first of all, Dr. Doyle, I want to thank you for your presentation. And just a couple of questions for you. So first of all, when you talked about CCS by the numbers and the funding sources, can you elaborate? I don't know if you know in terms of, we often talk about Medi-Cal and what Medi-Cal pays for. Where does Title V fit into that? Where Title V funds into paying for CCS services?
Yeah, I'm not the best person to answer that question. I might have to defer it. But I believe Title V is the program that funnels dollars into the state, and that's where the 50% federal, 50% state comes in.
Okay, but perhaps the department can clarify that, because I think that's through Medi-Cal. Okay, and then the other question I have is that so right now I understand for CCS, and I don't know if you're directly involved as an associate medical director, assessments are made whether someone qualifies or not, what services they get. Correct?
That's correct.
As you make those assessments, on what basis do you make those assessments? As a physician who works in the county?
Right. The way an assessment is made, there'll be a referral made to the program. First, it starts with obviously a referral form and medical records. The initial review is by a nurse, and then what happens is once they appear from medical records to look like it has a CCS eligible condition, they'll then start the eligibility process, contact the family. Once they've gone through residential and financial clearing, then they will start on the nursing care plan that looks at what else they need. And then at that point, once they've determined the needs, they'll start authorizing the providers and assisting the families with resources. But it's done first by medical record review. If there are not sufficient records, we'll get more.
Okay, and is there any communication about cost? This will cost the county, this will cost your premium payments from the state?
No,
anything like
not
that.
At all.
So there's no. So basically, this is independent of any sort of financial incentive or disincentive to the organization you're working for.
That's correct.
Okay, that's very important.
In fact, we do medical eligibility before we do those other eligibility determinations.
Okay, thank you. And also, I just had a question for Ms. Kenworthy. Thank you so much for being here, and thank you for sharing your story about your child. I first would note is that you lived in Humboldt and then later Yolo. But
and
then,
I'm in your I'm in your catchment.
In your catchment area, right? Exactly. And the fact is that the care that your child needed was not actually directly present in those counties, right? You had to actually travel to separate counties, or correct?
Yes, when I lived in Humboldt County, it's very rural, and there were flights, 5 life flights out of Humboldt County to San Francisco.
Right.
And
yeah. So and I know that our Medicaid program is often divided up by counties. So I know, for example, Yolo County is in one system, Sacramento County has a different Medi-Cal system. Okay. And the other thing is that you briefly mentioned at the end there was an antibiotic your child needed that was denied by their insurance. Can you elaborate a little bit about what happened there?
It wasn't it was a medication
Okay,
that was needed. It was I'm not sure what it is, but it's you would know. It's Zopanex,
okay.
And normally that was when he has pneumonia.
So
that's in the mix, and they told me no, I had to start with albuterol, and then that was on the formulary, so we had to, fail that if we wanted to.
So they didn't take account of your
Zopanex,
child's
so-
history, right, in making that determination?
Well, that's part of the challenge.
Right.
And,
Right, and the consequences of starting off with the wrong medication can be pretty significant, especially with a child who has special needs, right?
Mm-hmm.
I mean, you already know they failed on that, yet why would you want a trial, right?
Yeah, I know at one point when we moved
Uh-huh.
from Humboldt County to Yolo, my son is on a formula, he's G-tube fed,
Uh-huh.
and I had done all the calling and prearranging so
Right.
that the formula would be sent to the right place, and
Mhm.
the company failed.
Uh-huh.
And they said, well, we sent it to the last address we had, and I walked them through, and they said, oh, we goofed, I'm sorry. And I
Okay.
said, well, my child doesn't have food.
Uh-huh.
Oh, sorry. Like, are you not going to eat too? Because my child can't eat,
Okay.
And they told us, well, you'll have to, you can go get something. Well, the last formula that he had, I knew was on the shelf at Rite Aid.
Yeah.
And I went and bought it, and I fed it to my son,
Mhm.
and we landed in the ER because he was sick. He was throwing up, and he was aspirating. So,
Okay.
and so moving was traumatic for us. But amazingly, all the services came into play at that point. So.
Okay. Well, so it speaks to the importance of a regional system of care because, fortunately, I guess, the number of children who have significant, they're sort of spread out. The density, population density isn't as high. So, okay. Well, thank you. Thank you so much for your testimony.
Thank you.
Thank you.
Yeah, I'd like to follow up a little bit on the county medical directors, and more importantly, when you have a patient that is in a county that doesn't have all the services, and how does the system coordinate it so that all the services are provided, so we have sort of like a regional system? Can you kind of expand on that just a little bit?
Yeah, just one point too that Dr. Pan was making when he said the Medi-Cal varies from county. When the children have full scope Medi-Cal benefits throughout the state, they all have access to the same Medi-Cal benefits. And then if there is something that's medically necessary but not a Medi-Cal benefit, we do have a way we can access something called EPSDT funds that allows us to give them medically necessary things such as the Zopanex or those sorts of things. And particularly in the case where there are private insurance that doesn't understand that or has a very limited formulary benefit. To your question about how we coordinate services across counties, while the individual programs, CCS programs, are, if it's large enough, it's an independent county and it is administered by a local county, there are ways to get care. We can authorize care to another county if it doesn't exist in our county, and we actually can authorize care out of state if it doesn't exist in the state of California. And the way that's done is basically we work with the local provider to identify who they would like this child to be sent to. At that point, we request that an authorization form be sent, and then we coordinate care that way. And the way the medical directors work is we basically provide the medical expertise, the support to the nurse case manager and the nursing care team, and then from there we coordinate with the other medical directors if we need to.
And would that even include transportation?
Yes, yeah.
If, let's say, you're in a rural part of the state and you have to go even to another state, so it would
It
include
does.
the transportation and the coordination. The medical director would also be involved with that as well.
Exactly. I'll be honest with you, medical transportation, maintenance, and the funds are limited. However, if it's medically necessary, the transportation does occur and is arranged. And same thing, if it's a light flight or any even thing to support the whole team that needs to escort the child out of state, that is done.
Thank you. And I want to, just sort of a follow-up question or comment that Ms. Kenworthy made, and I was going to ask this question, is what do we do, and do we have anything in the queue to figure out individuals that once they become 21 and they transition to 22? I mean, obviously, you're going to be faced with that, and you've asked the question and you posed the question. I guess from a policy perspective, what does the state do? Do we have county medical directors or an entity that's going to be responsible to at least educate the patient of where these services are once you transition out? Is that something that all has been part of the conversation?
Go ahead.
Go ahead, yes.
I've brought it up in my county, what is happening. And I think that it's difficult. It is a difficult thing, but I think in the future we need to look at building that bridge for adult care. It's regional center helps some, but for a child with multiple needs who still needs to see a cardiologist, and I've just basically asked providers, will you see him beyond 21? No, yes, sometimes,
Right.
And so I mark it down, and then I start asking, okay, well, who would you recommend? And then I have to go through seeing, if we can get in to see that person. I've never been told I won't take CCS,
Right.
but I have been
Right.
told I won't take
Yeah,
Med-Cal.
and so, I mean, yes, we're dealing with the CCS program. I understand, statutorily it's age 21, but it does pose the question, that problem doesn't go away magically when you're 21, because if it did, you'd hope they'd turn 21 and the condition would be gone.
Yeah.
So, I mean, as policymakers, do we at least have to ask that question? I think it is our responsibility to at least ask that, and should that be part of the conversation with the administration, and, do we statutorily make those changes? I'm just thinking out loud, because I think these are the questions that we should be asking, at least to prepare the patient or the family. What do they do once they, age out of the program? So, yes, comment?
I'd like to make a comment on that. There are transition programs that are being developed in the independent counties. There are state standards that are in process. They haven't been executed statewide, but they are in place in some of the larger counties. I can at least speak for Los Angeles, Orange, and Riverside County, and we do begin transition conversations at 16, 18, and 20, where we try to do exactly what you're talking about. We meet with the families either by the phone or in the therapy unit, try to come up with a plan for what are the goals for the next 2 years. The biggest challenge is, however, identifying adult providers who have the expertise to take these children. And so I think you are very visionary in your thoughts about should we make some administrative changes to try to support these families and young adults
Right.
as they transition out. We've had to become creative. We develop our own internal databases. Some of our children's hospital physicians are willing to actually continue to see these young people into their adult years because they're well aware that their adult colleagues cannot take care of them, but there are nationwide programs that are trying to address that. But yes, we're very aware, and we would absolutely support any attempts to help us on the other end of 21.
Well, if you look, obviously, some larger counties have more resources. The concern I have is not that county, but the county that doesn't have the resources, that's in a more rural area, has less access to any kind of provider. So how do we continue that transition? And then I'm just, thinking, how that would be. So anyway, I don't have any further questions. I want to thank both of you for your testimony. We'll move on to item number 2. That's Department of Healthcare Service proposal for the CCS program. And I don't know about you, it's pretty hot in here. Is it kind of warm? Maybe, where's my staff? Can you check to see if we can get the air conditioner going? And we're going to invite Jennifer Kent, Director of Healthcare Services, who has vowed never to fly into Ontario again. Because I picked her up in Ontario, I'll share with you, a couple months back, and it was a nightmare because she couldn't get out. She got stuck in Orange County, but at least she flew into LA, right?
4 flight cancellations.
Four flights, so.
And an overnight in a business suit. Never again.
So she has something against my district.
Yes. I'm perfectly happy with the fine district of Sacramento.
Thank you. Anyway, Director Kent, welcome in light of the fact that you don't like my district.
Yes, great. Thank you. Good morning. Jennifer Kent, Director for the Department of Healthcare Services. And, this is an extraordinary time in healthcare. I feel extremely lucky to be part of the conversation that has been going on about CCS to date, as well as what we're going to be talking about in the next year moving forward. As Dr. Doyle gave a great overview of the program, it is extremely amazing to think that this program was started back in 1927. And so it really is one of the oldest health programs in the entire state, probably second only to some of the drinking water and early probably immunization and other types of programs that existed. So, it's with a great deal of seriousness that the administration is engaging in conversations about how we redesign the CCS program, and we do it thoughtfully, and we do it in a way that not only promotes better quality of care for these children, but continues to provide stability to the system that has developed in the state of California, that not only serves the CCS children, not only serves the children with other extraordinary health needs that aren't in CCS, but also serves children from other states. We're acutely aware that there are other states that do not have the same kind of network that we do. And so we, actually see a lot of, and obviously the children's hospitals and others can speak to this, you see a lot of children brought in to our state to be treated, and that is because of what CCS has been able to do over the course of its lifetime. So how we got to a conversation around CCS, I think it's a multi-layered discussion. CCS is obviously primarily a fee-for-service system that has built out over several years. When we started to evolve our healthcare delivery system in Medi-Cal back in 1994 to managed care, obviously there were certain populations that were exempted from the managed care mandatory enrollment requirements, and those were children with special needs as well as seniors and persons with disabilities. Obviously, as managed care has both improved and refined some of its delivery system processes, more and more populations in Medi-Cal have been enrolled. CCS has always maintained a carve-out exemption, with the exception of the counties that were, the counties that have always had CCS responsibility were responsible well before managed care was really ever extensively moved into the Medi-Cal program. And so we are not only interested in evolving the system to be better organized and to better deliver care, but we're also wanting to make sure that the children get the full array of services for which they're entitled. And I think that we all have stories, both anecdotal and some data, limited data, to suggest that there is a bifurcation in the system between CCS and especially for those children in Medi-Cal, where the Medi-Cal managed care plan is responsible for their non-CCS condition, the CCS program is responsible for their CCS eligible condition, but the coordination and the communication between those two systems for that child's entirety of care is certainly far from perfect. And that's really what drove us to start having the conversation in the first place, which is there has got to be one entity that's responsible for coordinating their care across the entire spectrum. We think that that's not only better for the child, but also gives accountability to one entity that we can track and monitor and have oversight of. So when we started the conversation around CCS redesign, what we were interested in getting feedback on was, what do we think works in CCS today, what doesn't work, and then if we were to put them into a different system, what would that system look like, and how would we develop the oversight mechanisms for that? The financing, as also was alluded in the earlier testimony, is incredibly complicated. CCS, because it is a three-way partnership between the counties, the state, and the federal government, there's different populations that have different funding formulas attached to it, and so it is not easy to kind of unravel some of those financing mechanisms. And so the proposal that the administration put forward in the summer of last year was not only attempting to go as far as we thought that we could in terms of the administrative and operational flexibility that we had, it was also limited in some part by the financing relationships that we, the state, have with the counties as well as with the federal government. And so the proposal that we put forward was to have the children in the county organized health systems. So there's 6 county organized health systems in the state of California. We proposed that 5 of those county organized health systems take full and responsibility for all of the CCS conditions as well as their Medi-Cal condition. They would be given a capitated payment to monitor and oversee all of that care. And then in 4 counties, in which our 2-plan model is, those plans and or counties could apply, and we have the option to decide whether a plan in one of those 2-plan counties should be taking care of those children. And so that is one part of the proposal that is both optional and voluntary. But in the county organized systems, what we've proposed is that starting in January, no earlier than January of 2017, children would be enrolled into those county organized health systems. The plans would be paid a capitated rate that accounts for that condition, and the plan would be responsible for coordinating that care. Partly through conversations with advocates and stakeholders, we modified that proposal slightly in August of last year, where we said that for some reasons that were voiced about the size and complexity of the population in Orange County, we proposed to move Orange County back 6 months so that it would be no earlier than July of 2017. We also heard a lot of concern from clinicians that they wanted to ensure that the clinical expertise and, to your point, Dr. Pan, about having evidence-based data and discussions about what was best in the interest of the child, was that we would require the plans to have advisory committee or almost like a peer group within the plan, composed of the plan's medical director, the CCS county medical director, and at least 4 local CCS providers, really to serve as kind of one of those groups that would look over cases, talk about what was appropriate, any kind of referrals that needed to be handled. And so each plan, as part of our proposal, would be required to have that, as well as obviously family CCS participants and advocates. I think one of the things that I want to highlight as part of our proposal, and this was obviously alluded to in the previous panel, is this thing, as we call it sometimes, the CCS cliff, which is these children come to an age in which they age out of CCS, and it has both mystified and caused a lot of consternation in a lot of the conversations around CCS improvements over the last several years, which is, what do you do with these children when they age out? And so one of the parts of our proposal has been that we are going to require all of the Medi-Cal managed care plans. So this is only for children within the Medi-Cal program, obviously, because we can't control what happens on the outside of Medi-Cal, but that for all of our plans, all 22 contracting Medi-Cal managed care plans, they would have to have relationships with these CCS providers for the children that were aging out of CCS and staying on into Medi-Cal. This may be the fact that a plan would have to contract with a pediatric CCS provider to the extent that an appropriate adult type of provider either does not exist or is not willing to take that case. And I think we've talked to the plans pretty extensively so far in a lot of our discussions, which is they understand that these children, even though they may turn 21, would still be best treated and seen by either a CCS provider or a specialty care center. And so we are going to be requiring, as part of our administrative authority and oversight of the plans, a requirement that all of our plans have those relationships in place so that when children are aging out, we have a network in place that helps both smooth that transition, as well as to the extent that it's appropriate, that there's a handoff to an adult type of specialty provider if that's actually called for. I think one of the other things that is important in our proposal is the thoughtful transition between the county and the state relationship between the plans and the county CCS staff. So how the pilot worked in San Mateo County in particular is that those county CCS provider staff are now co-located with the health plan of San Mateo. And to listen to the health plan of San Mateo talk about lessons learned, a couple of key things that I've always been struck by is that it's amazing what happens when you sit in the same room and in the same building together, is that it's a lot easier to coordinate when you're not in distant locations. And so that just geographically locating the staff at the plan has done a lot to help streamline some of those conversations. The second thing that I was struck by was the formulary, is the plan had not necessarily, and by their own admission, kind of thought through some of the specialty pharmacy needs that children with CCS eligible conditions would have that would be different than what their existing formulary was. And so right off the bat, they started seeing a lot of pharmacy denials because those CCS children were seeking refills. The pharmacies were declining them because it wasn't on the plan's formulary. And so what the plan did was change their formulary, and it was just one of those things that is part of a learning experience, but obviously their lesson learned also helps us do better transitions across the state when we talk about this with the other county organized health systems. The county relationship between the state and the county is something that we will have to have. We have started it, but each county, we are encouraging each county and each plan to talk first about how it will best work with each of them, because obviously what works well in Orange County may or may not work up in Partnership service area, of which there's 14 counties, some of which are dependent, some of which are independent. So what we are really trying to do is not only facilitate what will work best for the plan and the county CCS staff, but also how do we handle the financing that goes behind that. We want to ensure that that expertise and that knowledge base is not either jeopardized or otherwise not utilized. And so the plans and those CCS staff are talking. And so we are a part of it to the extent that we will step in if we need to. We will certainly have to have a conversation around the financing as it involves realignment dollars. But that's another key component of what we will be spending this next year talking about. The oversight of the managed care plans has been obviously of preeminent importance to us in terms of if you are going to put a very medically challenging population into the plans, what do we need to do as a state to ensure that it's both thoughtful as well as ongoing in terms of our oversight and monitoring. And so what we have proposed in the language, and I know that it was made available to the committee and to the participants at today's hearing, as well as we've shared it publicly before, is that we have developed a series of readiness review processes that we have with the plans that we have used in the past and that we would modify, obviously, to address this special population. But we would be doing full network assessments for these plans prior to any children being enrolled. We'd be making sure that they have contracts in place with CCS providers, that they have relationships with hospitals. Obviously, because of the regionalized nature of CCS, we are not under any impression, nor are the plans under any impression, that children could continue or could be required to stay within that county. They don't, most of them do not stay within the county today. We're not under any impression that they would stay in the county after the transition. It's more of how do you ensure that the child where they are receiving care today continue to have care, and if there are services that are not being provided or not being coordinated, the plan's going to try very hard to make sure that those are as close as possible. Obviously, to the Humboldt example, if there's no providers there, there's not much you can do, but you can do as much as you can to make sure that those services are brought. If we do our job correctly, the parents will have less of a role, I hope, in coordinating the care. I think that sometimes when you have a child with significant medical conditions, emotionally, it is really difficult to not only be there for your child in terms of providing comfort and keeping your family intact and trying to make sure that you're physically present, but what I have been struck by is a lot of these conversations with these CCS parents and families is the amount of time that it takes to administratively organize your child's care is something that we are looking to remove that burden. Obviously, we want parents to be involved. It is a family-centered approach, but we shouldn't have parents being the ones that are having to call and organize for food and transportation and housing. That should be the responsibility of the plan, and that's obviously what we're trying to do as much as possible, is have this whole child approach. I think one of the things that we have noted, and we had a CCS stakeholder meeting last month in October, is we have limited data today. A fee-for-service system is something that is not capable of monitoring or doing a whole lot of quality measures because of the nature of fee-for-service. It's a claim that comes in from a provider. It is a payment that goes out. We don't have a whole lot else in that system that is able to capture quality scores or whether it was appropriate or not. And so what we're really trying to do in this transition for children to CCS is how do we build the system to capture the data to make sure that what we have done is not only appropriate but reflects better outcomes. And so a lot of the time that we're spending with our plans as well as internally with our quality and data work groups is what are the metrics that are going to show that we've been successful, and then making sure that that's done in a transparent way so that everyone else can see that children with certain conditions met certain milestones or received certain care within an appropriate appropriate time, obviously, again, based back on what's either best practices or using evidence-based medicine as much as possible. I think that's really where we are trying to go in terms of quality improvement in the program. We have been really pleased with the response so far to the governor's signature of the carve-out extension, because I think that really set the expectation that we have a year to work closely and collaboratively with the providers and the parents and others to do a thoughtful discussion about what's appropriate and how do we improve not only the children that are going to be transitioned in those identified counties into the county organized health systems, but also to the other counties that we have not identified as being carved-in counties. And there are obviously, I know LA is one of them, where they have their own effort that they're doing, and to the extent that that effort bears fruit and shows great success, we are interested in having discussions and other counties learn from others in terms of improving the existing CCS program in those counties in which we are not proposing to move them into a whole person pilot or whole person program at this time. So with that, I will pause and I will happily take questions or explain other parts of the proposal as necessary.
Thank you. Dr. Pan, Senator Pan, do you have questions or any questions?
Yes, actually I have several. All right. So I guess first of all, thank you for your presentation. I have to admit that that I'm not sure I can buy into the description of your proposal or the agency's proposal is whole child. Mm-hmm. I think in my mind, whole child is very different than what's being proposed. I'd call your proposal managed care proposal. You're rolling them into a managed care plan, saying basically, and you've even stated right here in your testimony that the plan will do the coordination, the plan will do this, the plan will do that, and that's fine, but that doesn't absolve, in my mind, the responsibility of the state and our responsibility to ensure that these children get the care they need and that they get the quality of care they need. So I guess with that, I just want to first of all pose the question, and you did address, but what specifically is the top goal of the proposal that's been put forward? What is the main purpose of this change that's been put forward by your department?
I think that it is, again, we want children to be able to receive and have care coordination across the full spectrum, recognizing that CCS children may have a CCS condition, but they have other needs that are not met by the CCS program. And so having these children enrolled in the county organized health systems, and as we call it, the whole child model, which is it's the medical care, it's the behavioral health services, it may or may not be IHSS to the extent that it's necessary, any other ancillary services, that plan will be responsible for coordinating and financially responsible for delivering that entire spectrum of care.
So what you mentioned is coordination of care, which is certainly very important, and I would agree with that. But I wasn't hearing anything about the highest possible quality of care. But the goal is to ensure that we actually have the best system of care for these children. Mm-hmm. And yes, did you want to say something?
Yeah, so I wanted to highlight the fact that we in no way, shape, or form have changed or will change the CCS paneling standards that have been in place and have been developed not only for the providers but also for the facilities. The plans will be required to contract with CCS providers for those appropriate CCS conditions. And so the quality standards, and the Secretary has said this numerous times, is that we are not changing the CCS quality standards at all.
So again, I agree with your statement that we should ensure that people have qualified providers and people who meet the standards. Those of us in the quality improvement field would say that's the baseline, that's the bare minimum. Was there when the department developed its proposal, did the department perform? I know that initially there was a proposal for 4 pilots, of which really only 1 has been implemented. The second one's kind of partially. And so that hasn't happened, and we haven't, and truthfully, I have not seen, even on the one that was implemented, good evaluation data on outcomes for the children that were in there. There's some process outcomes. And then I know there was a stakeholder process as well, and there were very, some very experienced people in the stakeholder process, but frankly, at least the feedback I've received was the proposal did not reflect the stakeholder process. Was there, for example, the department perform a literature search on best systems of care for children? As I mentioned earlier, I served on a federal panel looking at systems of care for children with special needs. and this is not what it looks like, but perhaps the department has found something that I have not seen. Can you point to me a body of evidence that supports that this proposal is the best system of care we can provide for these children?
I would say that I will go to the first question about the pilots. The health plan of San Mateo is the first pilot. It was started in 2013. It has just finished its first full year, so 2014 was its first full year of implementation. We will be evaluating it as part of the close of our 1115 waiver that ended last month. So that will be done. So I think that the other pilots that were contemplated and that were proposed to the state for a variety of reasons, both financial as well as I think operational, were never successfully agreed to, both from the state standpoint as well as from the local standpoint. I think the financial considerations, especially at the time in which they were offered, was not something that was able to be successful. I think Radies continues to move forward. The progress has been slow, but we've been working with them. I think the last piece that we are in process with them on is all around financing, right, in terms of rates.
Yeah, and I know you weren't the director at the time, but the reason they came up with those 4 pilots, I mean, as I said, you're talking about one, but what did they, they had proposed, they said they were going to do 4 pilots.
Yes.
And they were looking at different approaches, right?
Correct.
And you mentioned that for financial administrative reasons, they couldn't do that for some reason. Although, again, the details have never been made clear to me. But that was the original commitment from the department. And there are, of course, in addition to the pilots that we have proposed, we also have different models across the country. One can even argue in different parts of the world as well. So I would go back to ask the question again: Has the department performed in developing this proposal a literature search of best practices, best models?
Sure.
Looking at that, and can you point to me the body of research that underlies this proposal as proving that this is the best possible system that we can do, that this is the best practice that's being proposed?
Sure. So we have looked at a lot of different studies and a lot of different models that have been done in states. I wouldn't necessarily say that they're evidence-based as much as they are either, if Robert Wood Johnson has done a, look at some model in, Massachusetts or Louisiana or something like that. I think that we are aware of some of those models. I think that we have stopped short of considering some of those for practical reasons.
Because when you say practical, meaning financial, meaning administrative, or was there a quality problem?
I think it's a variety of things. So some model, there was one in Louisiana that we regarded where I think they sent out nurses to homes. And that was certainly something that worked in Louisiana. They contracted with a private company to do that. And so there was some limited evidence that worked, but I think the number of kids that were done through that study was about 300.
And I think I'm talking more because we're talking more like, okay, nurses of specific services. I'm talking about systems of care. So, for example, most organizations would say that regionalized system of care, given the low prevalence of many diseases, fortunately, is that the population base that would be required to ensure that people that you could actually have a system of care is something that's very important. Fortunately, we're a big state here in California, but there are, as we know, there are many areas of the state where population density is fairly low. And even in Sacramento, and I appreciate you like my district.
So much that I live there.
There you go, exactly. I worked at the Children's Hospital there. I think we were a tertiary care center, and yet there were even some pediatric subspecialties that we didn't have the population density to maintain a subspecialist there, and that's in a fairly metropolitan area. We're So when we look at systems of care, I'd appreciate knowing what models and what research you've actually looked at, and even maybe getting some of the references for that research that the department has performed that says that this proposal, because again, I think the goal should be is that we're trying to provide the best quality of care for these children.
And I'm happy to provide that part of it. Is that it simply doesn't exist, as you know. Like you said, there's small populations that may not show a large statewide component. I mean, if you certainly know of a study, we're happy to take a look at it. I think that when you look at a delivery system redesign of the nature of what we're talking about, we have two models in California. We have a fee-for-service system and we have a managed care system.
Well, actually, we have... I mean, I think it's a little simplistic to simply say we have a fee-for-service and we have a managed care system, right? I mean, I think that...
In Medi-Cal,
yes.
those are the two systems that we
those are two
operate.
payment systems.
Correct.
Right. I mean, I think we need to
Correct.
separate payment system from...
Correct.
Right, how we organize the care. I mean, you have a payment system, and I know that's very important, but... So yes, we have a fee for service where we pay you per service, and we have a capitated model where essentially we pay, but those are payment systems. That's not systems of care, right?
Yes, but in a fee-for-service system, we pay for every single service, correct? And I think that there's no organization. So I think that's what we're struggling to do, which is organize/coordinate the care for these children in a better way.
Well, I would argue that there can be organization even for fee-for-service. I'm not an opponent to managed care. I don't want there to be any impression of that. But I also think the care system, and I've studied and worked with people who've thought of managed care, that it's beyond the payment system. So, for example, you made some mention about you get better data on a managed care system than fee-for-service. And again, this is not saying that we should stay with fee-for-service, but actually, in my background in health services research, we've actually sometimes found the opposite, because at least with fee-for-service, and again, it's not very good data, it's administrative data, billing data, but at least you have someone submitted a charge for everything they did because that's how they get paid. Whereas in a managed care system, unless you have it very explicitly in the contracts, because people aren't submitting billing information, there's less incentive to necessarily to actually document everything you've done. I mean, we can talk about EHRs and so forth and the challenges of pulling data out of EHRs, but unless you explicitly have systems in place, they're not actually collecting that specific data. And so sometimes actually managed care systems can be more of a black box when it comes to some of the quality things, unless it's very explicitly put in there that they are going to be collecting that data, because you at least minimum at fee-for-service, you have the billing data. People, because they have motivation, they want to get paid, so that's why they're submitting that data. So, I do think it's important that as we're moving forward. And again, I said this is not saying that we should stay for fee-for-service. But if we're looking at managed care, and again, managed care, you can have regional managed care. So you can have managed care without having to actually roll everyone into the current managed care programs. You can have a managed care system that's regionalized. You could still have an entity that manages care over large regions. That's not necessarily, the existing managed care companies, right? Depending on the distribution of population, that's still managed care. That's not fee-for-service, but it is a different, recognizing the difference in the populations that we're dealing with. In fact, people would argue that actually that is kind of, when we look at this very specialized population, and especially given the nature of the population, the services they need, the epidemiology of the population, that barring perhaps LA County is very large, but even some of the metropolitan areas, the base size, you have a challenge where you're going to, maybe I'll just, I think there's, and I think when we start looking at, for example, we're looking at chronic disease management, perhaps, we have basically three, talk about different buckets of kids on CCS, right? You have basically the neonates, or the NICU kids, that's a chunk. Then you have, you do have some conditions where are fairly acute, and then you have the kids who are like the one that was presented by Skinworthy, a child who has chronic conditions that are ongoing, right? And when we think about how we better manage those chronic diseases, the question is who is best responsible for that. In fact, many of the models that look at tying that to the primary care doctor, because we want to talk about true whole child, it should be based on a primary, a patient-centered medical home model. That is not tied to the plan coordinating care. It's actually tied to a care team coordinating the care. And I am concerned about this shift where you're basically saying, and you've said several times that it's responsibility of the plan. The plan will coordinate. Well, plans aren't very good at doing that in many ways. In fact, most of the research shows that because the patient doesn't have a relationship with a plan, they have a relationship with the people taking care of them. The care team. It may be a specialist team if they have cancer, or maybe primary care doctor with multiple, and so we should really be focusing our coordination resources to those groups, not a plan. A plan is simply an administrative entity to the people actually taking care of the patient. And in fact, one of the things that I have to admit I'm a little disturbed about, and it actually has to do with CCS, but there was a recent report that came out, I think Dr. Kaiser over at UC Davis did, and that the report just came out, said that outcome for patients with cancer, and this was looking more at adults, for people covered by Medi-Cal, was actually about the same as being uninsured. It was worse than every other coverage. And we know that we're having challenges with Medi-Cal payments and payment rates, and particularly in subspecialties. And I'm a primary care doctor, so I'm a big believer in primary care, and I practice in the clinic. But at least on the primary care side, we can. And so there's a part of me that gets worried because, and there's a lot more adults with cancer than kids with cancer. But why would we want to roll over kids with cancer into a system that's having such poor outcomes? Until we fix that. Why do we want to roll those kids into? Why do we want to roll kids with cancer into a system that right now is showing outcomes that are about the same as being uninsured and is worse than other forms of coverage? I'd be very disturbed about that. Until we can show that we can actually do this right, and this is a specialized population, so the density, and I think we had some conversations about this before. And I just want to talk a little about the epidemiology, because the most common form of cancer in children is acute lymphocytic leukemia, right? That's the most common. But just to keep that in mind, that's the most common. But statistically, every primary care doctor, because given the rates of ALL, would probably diagnose one new case of ALL in their entire career. Then we start talking about other cancers, and they're more and more rare. And being sure they have access to the quality of care, and what's the base program who's dependent, who's supposed to do that? Is it a health plan that's focused on one county? Or perhaps one could argue that it would be better, especially given some of the rare conditions, that it should be done in a regional or statewide basis. That asking every health plan to sit there and muddle through it on their own, I'm sure they'll try very hard. But I'm not sure that's the best way to do it. And that's why most people talk about, at least people I've talked to and to study children's special health care needs keep talking about regionalized systems of care. Because, again, the epidemiology. And I was working at a children's hospital. It's not like every cancer is the same. And the oncologists, the pediatric oncologists specialize in different types of cancer. And so when we talk about the most common cancer, and then we start talking about rare and rare ones, you are talking about people, sometimes there's only one person, or there's a handful of centers in the whole country that are good at it. And I know you appreciate that you mentioned that people may have to go out of state, right? But, again, I think that's a concern I have about the base. So I just want to be sure we're doing the right thing, right? I've always said we need to make our CCS system better. So I never said that we shouldn't consider how do we better manage, when we need more coordination care. I agree with you, the bifurcation is a problem. I'm a primary care doctor, took care of our CCS patients. That bifurcation was a problem. But I think whole child is not taking and saying we're going to take all these patients and roll them into a Medi-Cal managed care system, which probably does better on the primary care side, again, as a primary care doctor. But I'm actually worried we're losing the subspecialty care, and as magical as sometimes people think us primary care doctors are, I do need my specialist colleagues. There's only so much I can do, and I only have so much expertise. And I think that's very important. And that's in many ways probably why we started the CCS program to start with, because we recognize that these kids, many of them need that subspecialty care perhaps even more so than they need the primary care. I think they also need the primary care. But I would say we need to look at, when we look at the research, what we need to look at is regionalized systems of care. We need to look at how do we move the coordination of care closer to the families and based with the people who are actually taking care of the child and with their families, and not into an administrative entity. And I'm also a little concerned that in the administration's proposal that we want to eliminate risk-based payments.
That's not.
Well, no. You're basically saying that you're going to set a rate based on the whole pool. You're not going to actually say CCS patients should get more, that the plan, when you have this thing, you enroll them into the plan, would get a greater payment, right? I mean, that's the language that I saw in the proposed bill. And actually, if you want to tell me right here that is not what the administration is proposing, and we'll take that out, I'm very happy to hear that, because in fact, many of us who are looking at adverse selection issues, I mean, we actually think moving toward risk-based payments can be more important, because if you move, because there's at no point in time, no matter how good we're taking care of someone or how efficiently we do it, is someone with a chronic condition going to be cost the same or less than someone who's perfectly healthy. And so instead of trying to mash all these kids together, say, we're going to give you the CCS kids and we're going to negotiate one rate for all the kids in your county, and not have the CCS kids being a separate pool. And actually, I could argue maybe should even subdivide it even a little more there. But I think that's also concerning as well. I mean, because the counties then don't have, I mean, theoretically they could have the resources, but you have a new patient who shows up who has a very expensive disease, and you already negotiate a rate for the year. You're kind of stuck. That county's kind of stuck. What we don't want to do is create incentives for people to start cutting corners. So I mean, I have to admit, I have a lot of concerns about how the proposal doesn't correspond with what, at least I've learned about what people are proposing as being the highest quality of care for these patients. And I'm hearing a lot about, well, administratively may be hard, whatever, but I think that shouldn't stop us from doing what's best. I don't know appreciate your comments.
So I'm happy to explain the rate portion of the proposal. So we pay to the county organized health systems that have full risk and full payment responsibilities for the children today. So that's the Napa, Solano, Santa Barbara examples. Those rates are fully encapsulating not only the CCS costs, but the non-CCS costs because of the life of the plan and the responsibility that they've had for a long time. Those plans are responsible for organ transplants. They are responsible for cancer, for everything that you can think of. The only thing that has been carved out has been blood factor. It has been in, it has been out. We have recently carved it back out. But the responsibility for all other CCS conditions are fully enclosed in those county organized health system rates. When we did Health Plan of San Mateo in 2013.
And can you just explain to me why you think that's a good idea?
I think it's not necessarily a good idea per se. It's not a good or bad idea. It is a function of how long the rate has been established. The plans, just so you know, are paid on their own experience and data. So every year the plans submit full, we call them rate development templates, which is a full accounting of all of their encounters, all of their utilization, all of their cost. Our actuaries take all of that data, and what we do is, based on their experience, we build out a rate trended and going forward. So to the extent that a plan has a year in which they have an excessive number of CCS, either children or high cost, not only just for CCS, but for other populations, we account for that, we trend it, and then the rate is paid.
So what happens is that you look at the whole pool, and then you set a rate, and you said you have so many complicated kids, so forth, and what assurances do you have in place to be sure that the extra resources actually go to the people who have the more complexity? You simply created one rate for everybody. Now, admittedly, you work in the actuarial, et cetera, but how do you be sure that those resources actually go to the people that they didn't cut those people short because they had to make up something somewhere else?
So this is, a larger discussion of how risk-based payments and insurance work, but we pay the plans a capitated amount based on their experience and their data. They see their draft rates Obviously, if there's a concern or a question from the plans about whether we have done those rates based on the right data, we have discussions. Plans can get rates adjusted based on mid-year if there's an extreme case, like in the hepatitis C example where we did something extraordinary based on a very, very expensive drug coming into the market. Where we ensure that the plans are acting appropriately with the money that has been paid to them is we do financial monitoring of those plans on an ongoing basis. So we are monitoring their medical loss ratios, which means...
Okay, so I want to back up because you said financial monitoring. What quality monitoring are you doing aside from financial monitoring? How do you know that the people who have the complex conditions are getting the care they need?
Correct.
Because you just told me that fee-for-service isn't as good for quality because we're not looking. So I want to go back to how is that being made public?
Right, so I was answering your question about how do you make sure the plans are paying to make sure that those services are given to the right people. So do you want me to answer that first, or?
Well, I think the more important thing is how are you measuring that people are actually getting
Sure.
the care that they need, right?
So then the plans submit encounter data to us, and we have a variety of
So that's administrative
metrics.
billing data, right? Encounter data?
Not necessarily. It's also HEDIS data, and there's other measures that we do, and then plans have quality improvement projects that they do, and we work with them on an ongoing basis on some of those.
Okay,
But
and
HEDIS data is probably one of the other metrics that we use for
but
readmissions
HEDIS doesn't
and
deal
things.
with rare diseases.
Correct.
Right, because it's based on, because you need to have, a big base.
Yes.
And then we're talking again about children who have rare conditions.
Correct. So what we, as part of the process that we are engaging with advocates, stakeholders, academic institutions as part of this redesign is, and we would certainly welcome your input, is what are the measures by which we look at quality for rare conditions and or quality for the CCS population. We have an entire work group that is just on data and development of those quality measures. And so that is something that is being done not only for the managed care programs going forward, but also for fee-for-service in terms of how do we do that. And so that's a discussion that is in process, and I'm more than happy to include you in that discussion.
Okay, well, I will argue that it's going to be very difficult, especially when you start fragmenting everybody into these individual county plans. Because the numbers, it's a numbers thing, right? So what happens is that depends on how many people you have in the pool. If you're going to try to assess quality, you have to have a certain number, of patients that you're looking at, so you can actually measure in terms of the variance and so forth to know where things are. That's why and I think, for example, cystic fibrosis is a great model, and that's where the parents got together and said, we got to do something, right? We see this variation of care across, they looked at the whole country because that's what it took. They had to actually pool data across the country, and then they went about working to move everyone toward the best performing centers instead of and collecting that data. So, I think it's going to be very important that at minimum, you need to have consistent measures that work. And this is for a condition that's not, it's somewhat rare, but it's not the most rare. And I think it's fine to say that, but I am concerned that that we're not developing the kind of, we're not going to have the metrics to know what's going on. In fact, if you have a challenge doing the evaluation of the pilots and saying that you couldn't pull off two of them, one of them you only could do partially, and you got one and you still don't have the evaluation data, that's not a great track record to say, and we're going to be able to know what's going on, that we have the systems in place to measure types of quality that we're going to have coming out. If you can't even execute the pilots that were supposedly, again, you weren't there at the time, but that the department had committed to doing.
Well, we would certainly welcome your involvement in the data work group.
Okay.
Yeah. Thank you, Dr. Pan, for the questions and the comments. So, I've heard quite a bit about the redesign of the CCS program and, talk about it being a current fee-for-service and now potentially moving into a capitation system, the concerns that Dr. Pans has brought up with, coordination of care and, more importantly, outcomes and standards of care. Oh, and by the way, I appreciate the comment you made about assuming we're going to move forward with this, that the plans, Medi-Cal plans would have to have relationships with providers in the CCS program for after the 21. So thank you for that comment as well to the question I had earlier. So in light of the fact that the administration and the governor signed the extension bill, the one-year bill, but it's my understanding it's pretty clear that that was so that we can have a year to finalize and move forward and move into this new redesign of the CCS program. So I would assume that the administration is going to move forward with the redesign of the CCS program, correct?
That's correct.
Okay. And saying and understanding that, I guess the questions I have is, more importantly, I need to be convinced, as I'm assuming Dr. Pan needs to be convinced, is this system going to care for the children at the same or better care than they're currently taken care of? So I think that's the biggest thing and the biggest question that I have out there. The other thing that I would want to know is, within this year period, I'm assuming there is going to be a process where all the stakeholders will be involved, including the legislature, to air out and have these concerns addressed, and so that I can be answered. Because I would like to just state this, and I think this is very, very important, at least to me. And here is my biggest concern. And I understand that, you know, you work for the administration, you work for the governor, but my biggest concern is that I do not want to see this come out in a trailer bill in the budget process. And the reason why I need to say that very strongly is because I've seen other health systems go through it with healthy families, moved from from healthy families to Medi-Cal, and the concern I had was that the legislature, we didn't go through the normal legislative process. I'm not asking you to make a commitment that that's going to happen, because obviously you're not speaking on behalf of the administration, the governor's not here, but that is a concern, one of the biggest concerns I have. So I would hope that during this year process that we have input from all the stakeholders, but more importantly from the legislature. So that's a comment, unless you want to state that you don't think that the administration will bring it through the budget process.
So the language that we've put out in draft form is draft language, right? It's a starting point. And obviously we put it out in draft form in order to have the conversation with the legislature and the advocates and the interested parties. We are not wedded to the budget process. There is a budget element as it pertains to the county financing. So, you know, I wouldn't necessarily want to have you, understand that the financing that is between us and the counties as it pertains to realignment discussions, as it pertains to how we finance this, that is a budget component and conversation. And so I won't I don't want to dissuade you from how this would otherwise be done in a bill. It could be a trailer bill, it could be a policy bill, but this is the starting point that we want to have the conversation with both the legislature and the advocates about how we want to move forward.
Does the administration feel that they need statutory authority to do this?
I think that there are things that we would like in statute, because it sets both a marker down for there to be both oversight appropriately from both the legislature and others in terms of what is our responsibilities, what are the responsibilities of the plan. There is language that we believe we need as it pertains to the county relationship, as it pertains to financing. But for the rest of this, as you can see, we are amending existing statute. We have done it in a way that we are trying to be very transparent about what it is that we want to do, how we want to proceed. We've put protections in where we have noted as appropriately in terms of, no additional counties shall be enrolled into this proposal unless and until an evaluation is done. So there are things that in the language we feel bring both certainty to providers and to families and to the legislature about how we want to proceed, but this is put forward as a conversation starter.
Right. Okay, so saying that, and during this year process, should the legislature not feel confident enough that to address, like say, our concerns that children will be taken care of at the same or better rate, and should the legislature choose not to enact this statute, will the administration move forward administratively and still move this program forward to the redesign?
Well, I think that's, again, it would be a conversation if the legislature decided that this was not language that they wanted to entertain. The 1 year extension of the carve out will expire again in a year, and so that starts a different conversation. So and this was the intention of the governor's signing message, which is, we all have an interest in both protecting and improving the program. He signed the bill as a goodwill gesture to both start those conversations as well as assure people of this seriousness by which we approach this redesign effort. And so, again, this language is a starting point. We're happy to entertain discussions around it. But if the legislature decides that the language is not something that they want to either pass or put forward to the governor for his signature, then there will be a different conversation when that carve-out expires in a year.
So, I guess my concern is that there may not be a resolution, or that the legislature or the policy or the legislative body doesn't feel comfortable enough with this transition. And then if that occurs, a year is going to goes by very, very quickly.
Right.
We have budget, we've got, it's going to just fly by. And then what happens then? I mean, do we do another year extension? And what I don't want to do is find out that the administration is going to do this through executive order. Yeah. That's my biggest concern.
All right. Well, I don't think that that's where we are. Certainly not in the conversations that we have had both with the stakeholders and the providers and the others that we've been talking to all along, is we have stressed, and this is from both the secretary as well as myself, is how interested we are in doing this in a collaborative and cooperative and a successful manner. And so that is our starting point, and that is where we come to this conversation. And so that's my commitment, which is we are ready to roll up our sleeves and kind of get through some of these first initial conversations about what it is we want to do and how can it be done appropriately and correctly. If there's things that need to be changed, we want to hear about it. Some of this language that is in red is a reflective of us listening and changing. So it's not that we are wedded to a specific goal, but we do certainly have a path that we think is appropriate, and we want to work with people to get further down that path.
So I'd like to just bring up, again, reiterate a little bit what Senator Pan mentioned about some of the concerns about moving from the county medical director, and you'd made a comment that, parents shouldn't be involved with, the coordination of care, to a plan's responsibility. And, whether it's a payment mechanism or a health system or a coordinated care system, I agree with Senator Pan that, a health plan will ultimately make decisions based on the financial, dynamics of what's occurring with that patient. That's my concern. And I would like to see if there's a way we can have some type of, meld of those two processes, where maybe it's a non-interested third party that makes those decisions, which makes the best decisions of the patient. And if the actuarials are such that they're more expensive, that they be met to care for those patients, because they're extremely rare and difficult patients. So that's something maybe I would at least interject in the conversation, because if not, then you're going to get a non-disinterested individual who's going to make a decision based on economics. So that's kind of my concern, and I'd like to at least start that conversation. But and maybe we can follow up on that. But that's one thing that I like to bring forward. But I think things that I will feel comfortable with to sign off on legislation would be obviously to ensuring that there is absolutely no diminished access to individuals or these children. But that we also look at the best interest of the child in mind when determining where a child goes when we transition them over. And then, of course, I I also would like to see some benchmarks prior to the subsequent roll-in of an expansion of the child into the whole care system. And I think that needs to be part of the conversation. So, I mean, those are the kind of the key elements that I think are very important, and I think if we need to also have that conversation about have a third disinterested party to make those determinations as well. So I don't know if you want to comment on any of them at all or not, but I don't really have a lot of questions.
Right. I think some of the data that we shared at the stakeholder meeting in October is the start of some of that benchmarking data that you're referencing in terms of both 30-day readmits. So one of the key standards that health quality scores try to look at is whether someone, once they're discharged from an inpatient stay, whether they're readmitted within 30 days, and that's sometimes an indicator and a proxy for, what happened, right, in terms of why did you get readmitted so quickly. One of the data pieces that we shared at the Stakeholder Advisory Committee was when these children were discharged, how many days was it before they had a follow-up appointment, either with a primary care provider or with a specialty provider? 7 days, 14 days, 30 days. And the data, and this was on the CCS system today, not obviously in the managed care side, is a little troubling. Because there was a fairly significant percentage of children that did not see a provider 30 days after they were discharged. And I think that was one of those moments at the stakeholder meeting where people said, that's not great data. And we said, no, but it is data. And so we're presenting it in a way that those are the kind of benchmarks of how do we collectively improve care to those kids, because it should not be that a child is discharged from the hospital and then does not have a follow-up appointment within a month. And again, that was a problem that we looked at, and I think a lot of doctors that were on the committee said even if there was an odd variation in the data or the data is not fully captured, it's too big of a percentage to not take seriously. And so I think we are really interested in benchmarking, because we realize that to have people want to evaluate this means we have to set the place in which we are, and then we have to be able to demonstrate that we've moved the needle in a positive direction a year or two and 3 years down the road.
And besides benchmarking, maybe even outcomes as well, or
correct.
outcome.
Yeah. I agree.
And I definitely will be encouraged that we continue to work together during this process, the year, and as quickly as it's going to go by. But I need to feel confident that I won't vote for a bill unless I know all of these at a minimum are met, and that we have these stakeholder meetings.
Great, thank you.
Anyway, thank you. 3? Yes.
Thank you, Senator Hernandez. Actually, your questions prompted just 2 more questions. So, so first of all, I just wanted to ask in terms of Senator Hernandez referred to the importance of having a disinterested party, but also in terms of ensuring people have access to, if they get denied, that they let's get an independent review process or something of that nature. In fact, as a minimum standard here in the state of California, we're requiring all plans in the commercial sector to be Knox-Keene. So, so especially if they're going to take on these most vulnerable children, support requiring all plans to be Knox-Keene licensed who are going to take on CCS children.
I'm sorry.
I'm going to require all plans that take on CCS to be Knox-Keene, because that's the minimum standard we have to ensure.
I see.
That includes also the ability to appeal if they get denied services that they feel that are necessary.
Correct. So within our 22 contracting managed care plans today, 5 out of the 6 county organized health systems are not Knox-Keene. Health Plan of San Mateo is Knox-Keene licensed. The other plans that we contract with, both the local initiatives as well as the commercial plans, are all Knox-Keene. What we have done as a way of contract and as a department.
So is the answer yes or no? Okay,
I'm getting there if you don't mind. So we have Knox-Keene standards that we hold the county organized health systems that are not Knox-Keene to the same standards. I know that there was legislation last year that would have required the county organized health systems to become Knox-Keene. That was not successful. I think that what we have done to ensure that the plans are treating the beneficiaries in the same way is that the timely access and the other consumer protections that are Knox-Keene requirements, we have incorporated into our contracts, and we monitor the plans according to that. The only distinction and difference is on the independent medical review. How we handle that from a department perspective is that individuals have grievance and appeals rights through the county organized health systems, and so they come to us for hearing and dispensation if there's a dispute between the plan on a service and the beneficiary. And so that, in essence, is a proxy for independent medical review because we do it as opposed to the Department of Managed Healthcare. So, to the extent that the legislature was wanting to ensure that those plans are Knox-Keene licensed, that is something, obviously, I know that it was Senator Monning's bill that was not successful last year, but that was something that would certainly change that.
Well, again, that's a minimum standard we require of all commercial plans. Also, it's something the LAO had recommended, and so I hope certainly if we're talking about moving these vulnerable populations, that and being able to have another agency also involved in ensuring that people have access, that at least that minimum. I mean, it's a minimum step, should be something to be considered. And then the other question is that because we talked a lot about evaluation and outcomes and so forth, both of us, would you be open to actually having language in proposed bill that would mandate certain evaluations, including transparency, including managed care contracts, transparency, making those the actual terms and conditions of the managed care contracts that you have with the various health plans involved publicly available immediately?
Yeah, it's on page 2 of our language.
Okay, thank you.
Okay, Director Ken, I want to thank you for being here. I look forward to working with you.
Thank you.
And my staff will be reaching out to you probably tomorrow so we can start this process because I want to be intently involved as we move forward.
Great, and I'm happy to answer questions after the conclusion of the hearing as well.
Okay, I understand you're coming back up at the end?
Only if you ask.
Well, I may not ask. No. Seeing as how you don't like the San Gabriel Valley. Anyway, so we're going to move forward to item number 3. Thank you, Director Kent. Family perspective on the CCS program, the DHCS proposal, and ideas for CCS program improvements. We have an individual, which is Kathy Liu, and Nikita Wang won't be here, so in their place will be Donnell Kenworth. But let's bring everybody up. We have Yvette Baptiste, Executive Director of the Eastern Los Angeles Family Resource Center and Council Member of Family Voices in California. As I said, the second individual that will be speaking, we'll have them all come up, is Donnell Kenworthy. We have Michelle Sepulveda, Sherry Brady, and Lauren Messer. And I think that's it. And we can have those individuals come up and we'll have you speak in that order.
That's awesome.
And welcome. And good afternoon now.
Hello, Senators. Thank you so much for being very strong advocates for the family perspective in health services and the opportunity to speak to you to help inform this process. I want to give maximum time to the other parents, so I will introduce myself as an example and ask them to do the same as we go along. My name is Yvette Baptiste. I live in Northeast Los Angeles in Eagle Rock, which is 90041, and I work in Alhambra, which is 91803. I am, as you mentioned, the director of the Eastern Los Angeles Family Resource Center. We are an early start family resource center that serves families who have children with developmental and health concerns. We provide support, emotional support, and information and training. My wife and I have 3 children with special needs. My children were actually adopted from this county in Los Angeles, from the Department of Children and Family Services, or through them. My youngest was born in 1993. He would have been 22 years old this past Sunday. He actually died on Veterans Day in 2013 of causes unrelated to his medical condition. And I have brought his picture here. I'm sorry the audience can't see. But Andrew, what I love about this picture is it shows the occasion, which was probably one of the highlights in Andrew's life, in June of 2013, when he was showing off his chef jacket for his new job with the Patina Group, which is a catering and restaurant company here in Los Angeles, and they assigned him to the Hollywood Bowl. He was one of their prep cooks. We actually would not have predicted this outcome for Andrew at this moment. He was born prematurely with lots of medical issues. He was in the NICU for about a month. He has had a rare genetic condition, Klippel-Feil syndrome, KFS, which resulted in him being born with one kidney and the top 3 vertebrae fused in his neck. He also was diagnosed with epilepsy, had lots of seizures early on. Hey, Lauren. And he had so many seizures that the firemen in our community recognized him one day as we were shopping and pointed him out. Hey, that's Andrew. So frequent user of medical services. He received those medical services through Medi-Cal, which is available to adoptive families, and through our health insurance. He was seen by CCS panel doctors and specialists, primarily through Children's Hospital, but we also used our local hospital often in the early years. He was hospitalized at least once a month for his asthma or his seizure. The knowledge about where to find and access healthcare for Andrew was a daunting experience. Not very much was known. Well, I don't know if very much was known about the condition, but it is a rare condition. And in fact, before I was able to connect with CCS, I had to forcibly point out to my HMO team, you all were talking about team care, I had to forcibly point out during a session the funny way his back curved, and his neck didn't seem right. And they were like, no, he's okay. And I was like, no, you look. And they said, oh, she's right. I'm not that kind of doctor, so I really depend on the health professionals that I go to see to help with diagnosis. And I was surprised that they had not caught that condition. And I think it's because not many pediatricians see this condition, and that was evidence of that. In the picture here, Andrew had been seizure-free for 8 years. He had had no asthma attacks requiring ER visits for 5 years. He was in better health than most of the people he lived with in our household. This is due, I believe, to the concerted effort of care coordination that was provided through the CCS case manager, his pediatrician, who we saw until he couldn't stand it anymore, being in a waiting room with toddlers and infants. He used specialty care doctors at Children's for his asthma, his seizure disorder, and for his orthopedic issues. Those efforts were a team effort with the CCS program, the pediatrician, and my wife and I. And I think we got a pretty good outcome with Andrew because of that. All children should have, I agree with you, Dr. Pan, all children should have that guarantee. So thank you for your attention while I told my story, and I have the other parents here who are here to share
Thank you.
their
And
story also.
Whoever would like to go next, please do so.
Good afternoon, honorable panel members. My name is Michelle Sepulveda, and I live in La Puente and work in Pomona. First and foremost, I'd like to thank you and the state of California for the CCS program, which gave my son life for 16 years. Nathaniel was born on September 26, 1994, with a life expectancy of 10 days, with spina bifida and hydrocephalus, panhypopituitarism, adrenal insufficiency, and 13 other diagnoses. CCS gave us the tools to make his life 16 years strong. The care coordination built strong partnerships with his providers to support his medical, social, emotional well-being, which gave him a life of joy, happiness, much of what we take for granted today. Excuse me. His medical condition led to partnerships with doctors, nurses, and all allied staff to provide immediate and urgent care when medical crisis occurred. For you see, when adrenal insufficiency occurred, I gave him a cortisone injection at home, called 911, and the primary cell phone of his endocrinologist. Then directed the medical staff at the ER to begin his care. When his life was at its precious end, palliative care in his home provided us with mental health support to give him dignity with his last breath and journey home. We had social workers, nurses, and doctors support rapidly. When he needed specialty care services such as neurosurgery, now CCS supported him and paid for his needs to repair his shunt, antibiotics for his infections, and the growth hormone injections at cost of $800 a vial per week, not including the medical equipment that was needed to care for those. At the medical therapy unit, it provided more than just occupational therapy and physical therapy. It was a clinic-based model as well, with access to orthopedics, medical equipment, and home visits for our home to give him life and many smiles. Although the access to these services built partnerships and provided supports for him to thrive 16 years, we had challenges with prescription approvals, specialty air mattresses to prevent decubitus ulcers and bed sores, with countless documentation needed for authorizations from doctors, nurses, and of course, myself. This challenge provided access to other generic resources such as Regional Center and nonprofit funding such as Trinity Kids Care to fund his medical needs, which gave him what he needed, high standards. The medical home model gave him a home life full of smiles despite its many challenges of approvals. I remember the nurse case manager who graciously listened to his needs and provided social work support, a partnership which I fear will be lost in the upcoming changes of this program. The collaboration and access to care, much needed, gave him life. This needs to continue for such children as Nathaniel with vast medical needs. A wait time for service will mean life or death with children who have a need to medical specialty care immediately. I ask you to remember Nathaniel Nathaniel's life that CCS supported him when making the difficult decisions with access, partnership, and continue to build the bridge together so that no gaps in medical care occur and subspecialty care, medical equipment, specialty medications, mental health support, and surgical procedures are readily available and accessible. Thank you, Nathaniel's mom.
Thank you. I appreciate the comments. And how long have you lived in La Puente?
For a year?
How long?
About 4 or 5 months.
Okay, great. Welcome to La Puente.
Yes, good, thank you.
It's in my district.
Yes.
Whoever would like to go next.
This over here. I always think that I have a big enough mouth and a loud enough voice that I don't need a microphone, but I will use one anyway. Hello, my name is Sherry Brady, and first and foremost, I am Lauren's mom and biggest cheerleader. Lauren says hi. I am also the regional representative for the RettSyndrome.org Foundation and a parent volunteer for our Children's Hospital Los Angeles Rett Syndrome Clinic, which has been up and running for about 5 years now, thanks to persistence from myself and other parents, because it did not exist before. So speaking to specialty care, we were finding ourselves going to doctors that were like, okay, well, before we get started, could you tell me what Rett syndrome is? That wasn't very helpful. First and foremost, I'd also like to say that I'm very thankful that Lauren and I do live in the state of California. As a participant and member of the foundation, I have access and talk to families across the country, and we definitely have many more opportunities here than I know exist in other states. Just because it's better doesn't necessarily mean it's best, and there's always room for improvements. But I do acknowledge and recognize that we are very lucky in some instances. One of which is the fact that we do have the in-home supportive services program, which allows me to be Lauren's care provider and be at home with her and for her so that she can have the best life possible, because that is a all day, every day, 24 hours, 7 days a week job in order to make that happen. But it cannot happen with me by myself. I need services, I need support, I need resources, and CCS thankfully is now a part of that. I knew she was going to give her 2 cents. She always does. She agrees. Once in the program, and I'll come back to that statement in just a moment, the good news is that CCS does provide the additional layer of coverage for families and for children and individuals with special needs that we need. Rett syndrome is a neurological disorder that affects Lauren pretty much from head to toe. So it has taken away her ability to talk, obviously not her ability to be verbal, but she can get across what she needs to get across. She just can't do that with words sometimes. But it also has taken away her ability to walk independently in a functional manner, and it has taken away her ability to use her hands functionally. In addition, there's complications with seizures and scoliosis and GI issues, and you name it, and they can and do often suffer from and deal with those complications on a daily basis. Amazingly enough, most of them always still have a smile on their face and are enjoying life. Okay, sorry, she's been flirting with this one the whole time, like he's probably married, would you stop? As you can see, they have very wonderful personalities as well. Some issues obviously do arise with any care model, with any service. Some of those have been delayed approval of not only equipment but services and medications. And as we all talked about, when you're talking about a child with complex health issues, that can be life and death. That can be huge for them. Again, speaking with families across the state, there's also differences in not only the type of care that's received, be it some MTUs may have a treadmill and some may not, and some may have a therapist that is trained in a particular technique and some may not, but even differences in who actually gets CCS coverage throughout the state with a diagnosis of Rett syndrome. With Rhett, most of our families are turned away. Lauren actually was in CCS when she was younger as far as the medical therapy unit. She was then removed from that part of it. She continued on with coverage through for her seizures and for her scoliosis, but not the other parts of Rett syndrome. And now just recently has gotten back into the therapy, the MTU. But if we're going to talk about a service being a whole child model, I know you spoke earlier, Dr. Tan, about that, you know, what's the real definition of that? And to me, a whole definition of that is truly addressing my child from head to toe, not picking and choosing that this part of her can count and this part doesn't, because if she gets her seizure medication but she doesn't get her therapy, or if she gets, you know, this medication but not that medication, it doesn't work. She needs it all. And so I would like to see that taken into consideration. Let's see. I'm trying to go quickly. I was very happy to hear about the concerns and the fervor behind the transition with Lauren. Lauren is 18. She's a recent graduate of Whittier High School. That's probably why she was speaking up. She's like, you didn't tell people I graduated. And I know 21 is right around the corner because 18 came really quick, and I know 21 is going to come even faster. And I am fearful. Just in turning 18, I had trepidation about that and how life was going to be so different once she turned 18. 21, I cry myself to sleep some nights because I'm scared about what that's going to look like and what services are going to be available to her. I think, you know, we are dealing with individuals that have the maximum need, but there's already limited options. So as was said earlier, I just wholly hope that all things are considered, that parents are involved in every step of this process so that we make sure that there are no gaps, that there are services, that services do improve, so that we can maintain their optimum health, which would lead to the needs and the cost going down, and also lead to increased quality of life for our such valuable yet vulnerable members of our society.
Thank you very much.
Well, you've heard much of my story, but I am so thankful that you're very knowledgeably looking into this. And yes, I would agree that sometimes there are things that need to change with CCS. But I have a unique history in that I have moved from a rural county where we had CCS in the beginning, and things seemed to work unseen in the wings, and it was smoothly oiled. I rarely had challenges that I felt from the doctors or anyone else. They were like, well, this is the CCS panel doctor that you'll see, and there were doctors who came from the Bay Area, flew up to that area, and did clinics. So we did not always require transportation to get to them. It was more in emergency situations that we had to fly him where he was dying, and they had to fly him down here, or down to San Francisco to get the needs met. I appreciate that you're looking at this, and I would agree too, a whole child model. Many of our children are served by many different agencies. Our children not only have medical needs, but many times they have developmental delays, so they're served by regional center. My son is also served by EPSDT. And so that's a misnomer. We're looking at a managed care plan. I would agree with you, Dr. Pan. And moving from from Humboldt to Yolo County, I moved into a county that was, CCS was working much like it did in Yolo County, or in Humboldt County. It was well oiled. But then later in time, I believe Yolo became a carved-in county. And so now I was contacting partnership for authorizations instead of his CCS nurse, one that I had developed a relationship with, and it felt like it did go from a care plan to, this is not on the formulary. I'm sorry, this service isn't provided. And also me calling doctors who, before, when it was CCS, it was you have this appointment, you go, and you're there. I would arrive at doctor's appointments later to be told, I'm sorry, we ran your insurance, we don't take your insurance. You don't take partnership? No. And, getting my child prepared to come to a doctor's appointment out of school, he has extreme anxiety, which manifests in GI issues that aren't really nice, to go to the doctor. And we would arrive to have all the problems that we have with going to the doctor, but no appointment. So that's really disheartening. And just the, dealing with chronic illnesses is different. And I agree with you, Dr. Pan, putting this population into managed care to expect them to provide the level of care that we have had up to this point with CCS. I don't see the data that they're showing that this is working somewhere. I'm fighting it because I don't want to see this happen. And when they can show me data that it really works, then I'd be wholehearted about it, but I'm not seeing that. So I appreciate your time and so much for listening to us.
Thank you.
Is it on? I have a concluding statement from us, and I actually wanted to add, Senator Hernandez, you spoke about the transition. One of the things that happened for Andrew is, although he had been seizure-free and asthma was well controlled, his scoliosis was getting worse. And when he turned 18, the pediatrician that was seeing him informed us that he could no longer see Andrew, just, sent a letter. And I didn't know where to go. I tried going to someone somewhere on Valley or Las Tunas or somewhere that somehow had gotten this name, and we went there and they were like, no, I don't know anything about this condition, and no, we can't see him. I said, okay, I'm going to call CCS again, and they sent me to the specialty care center at Children's, and eventually we were able to find through that specialty care center and the nurse case manager, we were able to find someone close to our home in Pasadena that would see him for his scoliosis. But it took months of looking and hard work, and being assured that it's not that difficult for families is really important. So, in conclusion, I'd like to just say that we don't have a problem with change. Change is constant. And as long as we can ensure that protections for care coordination, parent participation in the decision making, both at the treatment level and at the policy level, are there, and that children have kind of an uncomplicated access to specialists with those guaranteed skills and knowledge, we can get behind that change, right? However, for our children with chronic life-threatening conditions, the devil in this plan is in the details that are not there.
Thank you. Any comments, questions?
Thank you. So first of all, I think that discussions about transition to adulthood, that's a huge issue, and in fact there may be some opportunities in looking at how we can do that. I myself have taken care of 30-year-olds who've had congenital diseases, and because a lot of the adults, they just, the good news is that we've gotten good enough that many of these children are now adults, have been able to live prolonged lives, and so, but the adult, because most of their patients tend to be elderly, they haven't had to learn about congenital diseases as much. They say that's why you went to pediatrics, right? So I think that in some senses we're dealing with a problem of success, but in that regard, I've also spent many hours on the phone trying to help my patients try to find an adult physician at the time when essentially my liability insurance said, well, you can't keep taking care of them anymore. You're not really covered anymore for someone that old, and at least have some idea of some of that struggle, because I know it was very hard. It's very hard. I do think with the CA and expansion of Medi-Cal that there's greater opportunities as well, because we had an issue there. I just wanted, because I know that a couple of you mentioned, just to get an idea again how rare some of the conditions are, because you mentioned your child had Klippel-Feil syndrome, right? So that actually occurs in every 40 to 42,000 births. So that means that each year, given the fact that we have about 500,000 births in California, we probably have about 12 to 14 cases a year in the whole state. And then you had so it wasn't particular syndromes. I couldn't calculate the number for yours. And Rett syndrome actually, the number was 1,000 cases per year. But the rule of thumb was 10% is California, so that would be about 100 cases a year again for the whole state. So again, that I think speaks to the importance of, that now what happens is that you have individual counties. Some are bigger, like LA. Some are smaller. And are we going to have consistency, right? We may have some counties do very well in their health plan. Maybe San Mateo is going to do a great job, but the question is everyone going to do that? And then you have the issue that I think was brought up about, is the person who's coordinating care, are they going to coordinate care, or are they going to be a gatekeeper, right? Because they know their plan's gotten one rate for everybody. And are they going to be a gatekeeper, or are they going to be a coordinator? Are they going to facilitate care, or are they going to be the ones trying to say no, 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 no? And I think we've all had experiences dealing with health plans where basically they always tell you no first and see whether you'd actually keep pushing or not. And then finally, so that is on top of everything else that each of you had to deal with. That's not something we want to have happen in the state of California. Even with a wheelchair, right? Yeah. I mean, they always say no first. I believe me, I've been there with the parents, and they say no first. I'm like, okay, well, we can keep working at it. But that's a lot of mental energy on top of what you have to do at home and getting. I've seen families, with the wheelchair and carrying them and trying to get up the elevator and so on, pulling into the parking lot and so forth. It's a tremendous amount of work to try to get for some of these kids. And so we need to be sure we do right by you. Thank you. Thank you so much for your testimony.
I'd just like to thank all of you for being here and for your testimony, and she's got to quit flirting. Thank you very much.
It's part of the mutation.
Thank you. I'm going to go a little out of order. We were going to skip and come back to item number 4, but we need to just have one individual who is going to speak in item number 5, because she has to catch a plane. So that's Dr. Lewis on behalf of the American Academy of Pediatrics, California Medical Association. So we're going to let her go out of order, give her testimony, and then she will have to catch a plane. So thank you.
Hear me? I actually feel very comfortable following the parents because I am also the parent of a child with special health care needs who's had many surgeries, many CCS providers, and without them, my daughter would not be a thriving 10-year-old. So I really appreciate what the parents had to say. Well, good morning, and thank you for letting me go out of order. I'm Dr. Gina Lewis, and I'm a practicing pediatrician and CCS paneled doctor at UCSF Benioff Children's Hospital, Oakland. I am also the immediate past president of the Northern California AAP, and I'm here on behalf of AAP and CMA to talk to you about what we've already talked about. A lot of what I've heard today I agree with. I am here to say that CCS in my county has worked very well to help me take care of a very complex set of patients. At the primary care clinic at Oakland, we see 40,000 visits a year. About 70% of the CCS children in Alameda County are seen by our clinic, and we are in the process of developing, like many other institutions and clinics like our clinic at the hospital, creating a center for taking care of complex medical care and coordinating that care. Because that whole patient model, that patient and family-centered model is absolutely right on. And the pediatrician who's on, the the ground with those families needs to be in that conversation. I think that together, working with CCS, we could really transform healthcare in a very positive way and make it better. Actually, CCS is doing a great job, as many of us know very well firsthand. And satisfaction, family satisfaction is quite high, 82 to 89% on some core measures. And CCS costs are actually falling. So data from 2007 to 2008 and 2012 to 2013, with some adjustment for inflation, showed spending dropped 17%. So CCS is not doing everything bad. They're doing a lot of great things, and they are the experts. I feel that I'm an expert. I don't know everything. I need help. I need my subspecialist colleagues, and I also need care coordination. Just the formulary fights in and of itself take me personally as a doctor 20 minutes per prescription that I have to get on the phone and say, yes, my patient needs Advair for their asthma. Yes, they need a wheelchair because they cannot use a walker. They have to have a wheelchair. So I spend quite a bit of time that I don't have on the phone and filling out forms, but I do it gladly because my goal is to make sure that my patients and their families get the best possible care. And I know that my CCS colleagues feel the same way. And I hope that we can all work together to make this a better system, not undo a system that's working very well. Not have a time frame where in 1 year we're going to get rid of a system that works well. We need some time to figure out what's going to work. We all want to make those changes. We all want to see what's going to work best. But forcing a time change when we don't have adequate data is dangerous, quite frankly. I think that the most important thing I've already heard, and I will reiterate briefly, is that if you give the same entity control over the funding and the decision-making, the quality assurance, if you will, it's going to be biased. It's not going to be equitable. I think that what's really great about CCS right now is that they don't have a financial interest. They have the best interest of the child at heart and in mind, and they're not trying to cut costs because not everything adds up in a capitated model when you have a child that needs particular surgeries or equipment that goes over budget. So I want to really underline that as my take-home message, that to me the most important thing that comes out of what we talk about is that we create standards and we create an oversight that is not the managed care plans. If the managed care plans are involved, and however we figure out the finances with CCS model, I am definitely, and I know AAP and CMA is definitely willing to work collaboratively on a solution, but we need to have a separate standards and oversight, separate from the health plans, that help ensure that the most vulnerable members of our society, children who do not have an inherent voice, don't get left behind, that they get everything that they need. Those kids with special health care need everything to get the best health care possible so they have the best quality of life. And I really think that that's the major thing that I wanted to say today. I want our CCS credentialed physicians to be able to see patients cross-county. If a child lives in a county where they don't have a provider that's an expert in their condition, I want there to be state-established standards to take care of these kids. So each group is not just guessing. Each county is not just guessing what the best model is, what the best formulary is. And of course, we're going to need rates that are sufficient to cover these costs. Many of us who serve children with special health care needs and their families see the need for a medical home that includes the primary care doctor in the center. We were talking about the whole patient model. Why doesn't CCS pay me to take care of patients? Why don't they pay my developmental and psychiatry colleagues to take care of those patients? We're all doing the same work. We're all communicating with each other to do the same thing, the same goal, to have better quality of life for this patient. So I want this group to figure out a way to allow families and patients and pediatricians and subspecialists in pediatrics to continue to work with their CCS partners and come up with a better plan with a timeline that makes more sense, that doesn't cut us off in a year, that doesn't say, oh, well, we weren't able to come up with the data, so let's just move ahead. That does not make sense, and it's not safe. And I, for one, feel very passionately about this, and I'm not going to let that happen on my watch. We need to do this in a thoughtful way, evidence-based, together, collaboratively. And until then, the status quo is really pretty good. Thank you.
Thank you very much. And you have a flight, you said, you have to catch?
I do.
Okay. Well, have a safe flight.
I'm so sorry. Thank you.
No problem. Thank you. Okay, we are now going to move on to item number 4, the County CCS and Regional Collaborative Perspectives on the CCS program, the DHCS proposal, and ideas for program improvements. We have 3 panelists that are going to be coming up. We have Dr. Block, Medical Director, Children's Medical Services, Los Angeles. We have Elaine Lopez, Registered Nurse, Nurse Care Manager, Los Angeles County. And we have Laura Simone, Director, CRISS Project Director, Alameda County Medical Home Project, Senior Policy Analyst, Lucille Packard, Children's Hospital. So we can go in that order. If you could please proceed, and good afternoon and welcome.
Good afternoon, committee members, and thank you for the opportunity to address you today. My name is Dr. Edward Block. I'm the Medical Director of Los Angeles County Children's Medical Services and CCS Medical Director since the year 2000. I've been a physician at CCS for the past 18 years and a member of the California CCS Executive Committee for 17 years. While the Los Angeles County Board of Supervisors does not have a position on the state's proposed whole child model and CCS redesign proposal, I am basing my testimony today on my experience with CCS in Los Angeles County and our interaction with other counties and with DHCS. The goals of CCS redesign are important and achievable even without many of the changes the model proposes. Today I'd like to focus my remarks on our concerns about achieving those goals. And I want to start by saying that I was given 10 questions to try to focus my remarks, and so I will apologize in advance for doing this one question at a time. First, the question, what works well? The several decades of experience counties have had administering the CCS program has resulted in a constantly evolving program serving children and youth with a diverse set of serious, often life-threatening, complex medical conditions. What has worked well includes 1, CCS standards. I know this has been mentioned several times today, but I will mention it again. CCS standards provide a high level of quality of care which benefits all children and youth statewide, such as the adoption of CCS standards in neonatal intensive care units. All children receiving care in CCS-approved facilities benefit from CCS standards, including those who are fully commercially or privately insured and not in the CCS program. 2, medical case management. Service authorization, case management, and care coordination are provided by public health nurses under the supervision of board-certified pediatricians as required by the 1999 state staffing standards document. In a public health setting that facilitates child and family-centered care coordination, focusing on the health and well-being of the child. 3, robust provider networks. Regional and local robust provider networks of CCS paneled physicians and CCS-approved special care centers and tertiary care hospitals and related facilities form a statewide system of care for children and youth with CCS eligible conditions. 4 in the list of what works well. Continuity and consistency of case management. Approximately 20% of our county's caseload has congenital disorders or other CCS eligible conditions requiring care from birth and extending for several years, at least several years. CCS provides consistency in care coordination and case management to assist parents and families in navigating their children's care. 5, linkage with our medical therapy program. In Los Angeles County, close coordination and collaboration with our medical therapy program and its 25 medical therapy units allow for seamless occupational and physical therapy and medical case conferences for children and youth. This rich experience provides a foundation for counties to continue to implement program enhancements and efficiencies. My second question was, what does not work well? There is room for improvement. There's always room for improvement in a few specific areas. 1, coordinating care with non-CCS primary care providers. Again, this is something that has come up earlier today. Children and youth with very complex or multiple CCS conditions often receive the majority of their care from their CCS service providers. Currently, in LA County, and at least for the 15 years since I've been medical director, our nurse case managers coordinate all services related to the CCS eligible condition, including their primary care as it relates to the eligible condition. And that means for all of our children with the most complex disorders, virtually all primary care is authorized by CCS to the most appropriate CCS paneled provider. Increased care coordination with these patients' non-CCS primary care providers would enhance CCS case management. The Medi-Cal assigned primary care physicians for children with the most complex disorders in our program, by far the majority of those primary care providers assigned by Medi-Cal are not pediatricians and are not board certified in an appropriate primary care specialty. 2, establishing true medical homes for children and youth with CCS eligible conditions. In Los Angeles County, the majority of Medi-Cal managed care primary care physicians are not board certified pediatricians and cannot function as special needs medical homes. As a result, we authorize primary care related to the eligible conditions to board certified physicians for children with complex conditions. In Los Angeles, we have established criteria for medical homes that families can weigh in on during their initial assessment call to assess the quality of the designated medical home. 3, transitioning to adult providers. Again, common themes keep popping up. Broader networks of adult subspecialists are needed to provide care for CCS youth as they transition to adult care. In Los Angeles, we have partnered with a number of major medical center providers to build on our own network, our local network of transition providers. That network seems always to be insufficient. 4, one-size-fits-all case management. Case management based on the complexity of the child or youth's condition or set of conditions is necessary and would improve efficiency. In Los Angeles, we are in the process of implementing program-wide changes based on our own nurse case management redesign pilot that varied case management protocols and interventions based on the medical complexity of the child's condition. And this project has allowed us to capture valuable data with which to plan future improvements. And it's the kind of data that, in my opinion, does not exist in any other part of the system. Third question addressed to me. perspective on DHS CCS proposal. The CCS redesign proposal requires careful considerations that must be factored into the final proposal, and these include: 1, potential loss of expertise in the care coordination of children and youth with special health care needs. Currently, county nurses, in consultation with our physicians, provide care coordination, case management, and service authorization for children and youth in the CCS program. The medical complexity of the majority of LA County's caseload requires medical oversight for case management. Administrative oversight, delegating care coordination to administrative staff rather than specialized pediatric physicians, would not provide the necessary medical expertise to determine the appropriateness of requested services. 2, disruption in existing services. Managed care plans will need to establish new networks of service providers, potentially disrupting the long-established networks of CCS paneled providers already in place, providers who the children and families trust. 3, reduced patient choice and access to services. Because managed care plans must establish contracts with providers, it is probable that the resulting networks would have fewer providers, thereby limiting patient choice and access. 4, possible reduction in service quality. Currently, county CCS programs conduct case reviews in performing their care coordination and service authorization duties. This helps to reduce deviations from CCS standards. When deviations are identified, medical staff works with providers to resolve those issues. The proposed whole child model should require managed care contracts to clearly identify how current CCS standards will be monitored and enforced to mitigate any reduction in service quality. And finally, in this section, erosion of CCS standards. In Los Angeles, we work closely with our 2 managed care plans, LA Care and HealthNet. The delegation of risk and responsibility by plans and plan partners to independent physician associations, IPAs, and medical groups could further narrow the networks of approved providers and dilute knowledge and compliance with CCS requirements. Strictly applied and rigorously monitored quality and performance standards assessed at the IPA and group level in collaboration with the plan, the state, and local CCS administrators would facilitate maintenance of CCS standards. We recognize the need for improvements in CCS and believe that many of the redesign goals, such as patient and family-centered and whole child care, can improve efficiency and cost effectiveness. In fact, Los Angeles and other counties are implementing innovations to address these goals. Question number 4, how will CCS staff be affected by the DHCS CCS proposal? The whole child model would require DHCS to contract with a managed care plan for the coordination and integration of Medi-Cal and CCS services for CCS eligible children who have Medi-Cal. Consequently, the case management and care coordination services currently provided by LA County CCS would be eliminated for approximately 90% of our current caseload. We would therefore anticipate a similar reduction in our case management staff and related support staff. Question number 5, what is the role of county nurses and medical directors in determining medical eligibility for CCS? All determinations of medical eligibility and medical benefits are the legal responsibility of our physicians. Our CCS physicians have delegated to our nursing staff within certain protocols a great deal of routine decision-making in medical and clinical areas, and certain types of requests or referrals always require final review by a CCS physician. Similarly, even rather routine appearing requests and referrals often reveal a gray area or a new technology, etc., which requires further physician review. Also, all denials that meet criteria for due process are appealable by families. I should mention that services deferred to a primary payer, such as a commercial payer, are not appealable to CCS. Question 6, how CCS care coordination is done in San Mateo versus other counties. I would prefer to defer this to the San Mateo people. I can tell you that it is my understanding that San Mateo is currently partnering with the health plan of San Mateo, HPSM, in a demonstration project serving 1,500 patients with the plan assuming financial risk for all care, including CCS and non-CCS conditions. Roles for the health plan and county were jointly established. San Mateo staff is co-located at the plan, and the health plan subcontracts with the county for financial, residential, and medical eligibility determinations, utilization review, case management, and care coordination. San Mateo County provides oversight of all county staff. In Los Angeles County, CCS determines all eligibility and provides all case management and service authorization for over 50,000 children and youth. Question about county financing in CCS and realignment funding. I have to admit that I do not have the expertise to comment on financing issues. The 8th question was, in counties where CCS is carved in versus carved out, what are the roles and interaction of the county organized health systems and the county CCS staff for CCS services? Currently, our interaction with other counties occurs when patients relocate to other counties or receive services in another county. A small proportion of clients transfer in or out of LA County each year, and a small number receive services in other counties while having cases in Los Angeles County. Because all CCS services are through CCS paneled providers, patients essentially have a statewide system of care. However, sometimes patients are not allowed to continue care with their long-standing Los Angeles-based physicians who are not in the new county's plan network. That's not a specific statement about county organized, but just our experience with other counties in general. Next to last, which issues arise for counties if non-Medi-Cal CCS children remain separate from the Medi-Cal managed care plan? In Los Angeles County, about 10% of our clients do not receive Medi-Cal, so current CCS county functions would need to be continued only for this 10% of children and youth. Maintenance of 2 CCS systems of care is likely to result in confusion for families if they move back and forth between systems. If Medi-Cal coverage is lost, for example, confusion for current CCS service providers, as those who are included in the managed care networks will receive a capitated rate for some children and fee for service for others, and disparate service provision. It is likely that non-Medi-Cal CCS clients will have access to a broader network of providers and receive a higher level of medical care coordination than children and youth receiving their CCS-related care through narrower managed care networks. And finally, what would happen in 2 plan model counties, such as Los Angeles County, if CCS is carved in? First, we would anticipate that shifting care of CCS-eligible conditions to managed care in Los Angeles would result in significant disruption for all participants. A decision would be required regarding the participation of one or both plans. Following this, the plan or plans would need to contract with DHCS, and MOUs would need to be developed between the county and one or both plans. that would assume the care of the children and youth with Medi-Cal and CCS eligible conditions. If only one plan participated, children with CCS eligible conditions would need to transfer to that plan. If both plans participated, it is unlikely that the MOUs would be identical, resulting in potentially different roles for the county with each plan. Plans would need to contract with CCS paneled physicians and CCS approved facilities. It is unknown at this time the degree to which current CCS providers would become part of a managed care network. The proposed statutory changes indicate that medically necessary care not available through the plan's network would remain the responsibility of the state and county. Theoretically, at any point in the child's or youth's care, depending on the services covered by the plan, the county could need to assume coordination of and some costs related to services not covered by managed care. Los Angeles County CCS would need to identify those children and youth with Medi-Cal and cease all case management services for those children. CCS would still provide residential, financial, and medical eligibility determinations, annual case reviews, and medical therapy services for these children. Because up to 10% of CCS participants do not have Medi-Cal, CCS would still be required to maintain a small cadre of public health nurses and support staff and physicians to provide case management and care coordination services. Significant staff reductions would be anticipated. Patients currently enrolled in managed care plans for care unrelated to their CCS condition would need to receive their CCS care as well from those providers in the plan's network. It is unclear if the managed care plans would establish contracts with anyone's current CCS paneled providers. Parents would no longer be in contact with a CCS nurse case manager once eligibility was established. All questions regarding services related to the child's CCS eligible condition would need to be addressed by the managed care plan. Once it was determined that a plan did not cover a medically necessary service, CCS would need to review the request and potentially authorize the service. This could result in service delays and confusion among parents navigating these authorization processes.
Thank you. We move to the next presenter, please.
My name is Elaine Lopez, and I'm a registered nurse, and today I'm testifying as a member of SEIU Local 721. So my testimony does not reflect official county position, but rather is in a personal capacity on behalf of SEIU's CCS workers statewide. I've been with the CCS program working in a variety of capacities for 15 years as a nurse case manager. Currently, I am using my 31 years of experience alongside a small group of highly tenured nurses to determine medical eligibility, triage cases according to complexity to other public.
Don't mind moving the mic a little closer because can you hear back there or not? No?
No?
Yeah.
Oh, I'm sorry.
Yeah, if you can just.
Okay.
I can hear you, but I think they're going to have a hard time hearing you. Thank you.
Okay, where was I? Okay, let me just start here. Currently, I am using my 31 years of experience alongside a small group of highly tenured nurses to determine medical eligibility, triage cases according to complexity to other public health nurses, and make referrals to ensure that children and families get critically needed care as soon as possible. I have always seen my role as one of a patient and family advocate. And even in my current capacity, I often interact with families to get information about their situation. I'm often one of their first encounters with the CCS program. The existing CCS program has evolved alongside medical science to ensure that children with complex, high medical needs have access to comprehensive, family-centered case management provided by our county nurse case managers and public health nurses. The conditions of these children we see can challenge physicians who may not have seen these cases very often and completely overwhelm families. Our nurses are a conduit to help link families and children with the most appropriate treatments and the very best specialists, and to make sure that children can access the care they need. We provide families with the support and information they need to navigate the challenges of their child's medical and social needs. That promise of access starts at the determination of a medical and financial eligibility and continues with the coordination of services. Surprisingly, you cannot delink these functions, as the treatment for certain medical conditions is so expensive that even families of fairly decent means can become eligible, as their medical costs would exceed 20% of the family's income, thereby making them eligible. We often form a strong bond with the families we're working with. These bonds are reflected in the high rates of family satisfaction with the CCS program. Close to 90% of our families reported being satisfied or very satisfied with CCS case management. Clearly, there are benefits and drawbacks of the current model. The main benefits of the CCS carve-out come from the role of the county workers and our partnership with specialty care centers in delivering the right care in the right setting for CCS-related conditions. Our role as seasoned, mission-driven county nurses who play a neutral, non-fiscal, third-party role, ensures that our clients, the patients and their families and caregivers, receive the appropriate level of care needed. Years with the program have given us an intimate knowledge of the landscape of providers for specific conditions and needs. While I am very proud of my role and our program within county, the program is not perfect. There is a shortage statewide of a very few categories of specialty pediatric providers for CCS clients. And in our region, geographic barriers to accessing care can be significant. One concern we have is that shifting the program to managed care would worsen rather than alleviate some of these challenges. Another challenge that I faced on the eligibility and service authorization side of the program has been that we often are not dealing with peers, medical professionals who understand complex pediatric care needs when trying to coordinate care with the health plans. This fundamental lack of understanding does cause unnecessary delays and frankly seeds some concerns in me with the whole child model. While we obviously need to improve those communications, the whole child model proposal would uproot the very core of the program that has been working for children and families and place these medically fragile children in the hands of the plans in services of administration, financial streamlining, and simplicity. The whole child model envisions a world where our case management and service eligibility work would eventually transfer over to the health plans. This would result in a loss of a highly specialized Los Angeles County brain trust of over 200 staff, nurses, and support staff who have significant expertise in CCS children and families, the barriers they face, the supports they need, and the landscape of specialist providers. The health plans have a long way to go to develop the expertise we bring, and that's part of what empowers our families to feel confidence that there is a blueprint for getting through what they're facing. It is difficult to say how the department's vision would play out since the model they've laid out is untested. Even San Mateo continues to rely on the counties for case management, and there has been no independent evaluation of that county's experience and lessons learned. Given the high needs of the children and families in the CCS program, the high risk involved in trying to alter how those services are delivered, we would urge the state to put the interests of the children and the families first. Any changes should be done slowly and should be evaluated along the way. This would need to start with a thorough examination of the current San Mateo model and a frank conversation about where there are knowledge gaps within managed care plans to assess plan readiness. We would urge the state to consider preserving the county-led functions of case management and service authorizations, as they have served our families well. Can we do better? Sure. But we should solve the problems rather than try to fix the pieces of the program that are unbroken. County nurses who perform these case management and eligibility functions have also largely been left out of the redesign conversations to date. We would urge the legislature and the department to ensure that our perspectives and experience inform any proposed changes, as with this hearing. Thank you.
Thank you very much. Please proceed. And if you can bring the microphone close so that everybody can hear. Thank you.
Very, very close. Is that okay?
I don't think it's on. Go ahead, try it again.
You spoke from
There you go.
There we go. Okay. Good afternoon. I'm Laurie Soman. I'm director of the Children's Regional Integrated Service System, or CRIS. CRIS is a collaborative of family support organizations, children's hospitals, pediatric provider groups, and county CCS programs in a 27-county region of Northern California. Since 1996, we've worked successfully to build a more effective family-centered system of care for CCS children in our region. My comments today are based on core principles that this rich group of partners has developed to address healthcare delivery to children with CCS conditions. I'm going to focus on 3 specific questions, and let me just note in advance that the comments will sound familiar to what you've heard from other speakers, and I think this just is testament to how much families, providers, counties, and others have spent time considering the CCS program and how much agreement there is about what works and what doesn't work. So first, let me say we support the concept of CCS redesign. We believe CCS has critically important components that have driven excellent health outcomes, and you've heard something about that, for vulnerable children, and also driven that pediatric system of care that serves all children in the state. And these components should be preserved regardless of any changes that are made through redesign. But at the same time, we recognize CCS is 90 years old, or almost, and it will benefit from a fresh look and new approaches. So let's start with what works well in CCS. And this will sound a bit repetitive, but bear with me here. Most importantly, CCS helps ensure that children with serious and complex medical conditions get to the right care, at the right place, at the right time. And CCS can do this because of 3 specific components that we would stress must be retained in any kind of redesign proposal. So the first is that strong statewide system of pediatric specialty care with hospitals, multidisciplinary special care centers, and pediatric subspecialists, all certified according to state credentialing standards that are built on pediatric training and expertise and national quality standards. The second is decisions about access to medically necessary services that are made by pediatric experts. And this is typically through a strong partnership of pediatric subspecialists and county CCS medical staff, and then driven solely by children's medical conditions and the child and family needs. And then the third is that children's access to the statewide CCS provider network is present with no artificial barriers based on geography or narrow plan networks. So in other words, kids get to the right provider based on the facts of their condition, whether that provider is across the street or across the nation. What about CCS needs improvement? Well, we know this is an almost 90-year-old program, and we believe that there are many changes that we should make to CCS to strengthen the program. Let me just mention 4 of them. So the first, again, this is a common theme, we do need to address the whole child. And we think that we can begin by serving the whole child through strategies like extending CCS authorizations to include primary care, which is something Dr. Lewis mentioned in her testimony, and improving CCS care coordination with medical homes. Second, we think we need to implement intensive care coordination for high-need kids and families, including coordinating care across the multiple systems that are used by these children. That's mental health, special education, developmental disabilities, and more. The third is include families and youth at every level in planning and decision-making concerning CCS, because this program is for them, and underwrite their costs so that we can enable their effective participation. The fourth is bolster quality improvement in CCS by restoring the state pediatric expertise we've lost over the last decade to budget cuts and staffing cuts, and by expanding the statewide quality initiatives that are specific to CCS children. And the good news here is that, as I think you've gotten an idea of, some of these strategies already are being implemented successfully by county CCS programs and children's hospitals with strong family involvement. So what is the CRIS perspective on the department's proposal? Let me start by saying we strongly support the department's commitment to address the whole child. But our concern is that the core concept of the proposal does not meet the CRIS principles in two critical ways. The first is the department's proposal would give responsibility for CCS services to traditional Medi-Cal managed care plans that were not designed for them or their complex, often rare conditions. The plans aren't required to demonstrate internal pediatric expertise, and they aren't required to include the full spectrum of CCS certified providers. So in contrast, CCS is a nationally respected, population-based, and I would say managed care program that was designed specifically for these 180,000 kids in our state now. We believe this is a classic mend it, don't end it scenario, and that the stakeholder process should focus on implementing and evaluating specific improvements in CCS. So the second piece is that the proposal would give the managed care plans full responsibility for medical decision-making and full financial risk. We're very concerned that medical decisions will not be made solely on the basis of the child's medical conditions, particularly coupled with the plan's lack of pediatric expertise. We strongly recommend that the CCS program, with its long history of pediatric standards and expertise, remain in control of medical case management for these children, regardless of what other changes are made in the program. This is the critical CCS role that ensures that children do get to that right care, right place, right time. I want to clarify one thing. This is actually how the system currently works, even in the 6 counties that are referred to as having a CCS carve-in. In those counties, even the ones with carve-in, the county CCS programs are responsible for medical case management of CCS conditions, just as they are in the carve-out counties. The difference between carve-in and carve-out counties is who is paying the bills for CCS services. In the carve-in, the plan, which is at risk, is paying the bills. In the carve-out, the state is. So what the department is proposing here today, in fact, is a radical change that would shift responsibility for medical management of these children from CCS to the plans. So I need to stress this is an experiment that has not been tried or evaluated before, and that we would say poses serious risks for CCS children. So in conclusion, let me just say, yes, we have very serious concerns about this proposal, and particularly that proposed shift of medical case management from CCS to the plans, and therefore we can't support this proposal in its current form. But at the same time, I believe the department and CRIS share that same goal of wanting to improve services for CCS children. We appreciate the administration supporting AB 187 and giving us some more time to plan for changes. And so I want to underscore CRIS's continued commitment to work with the department and other stakeholders to implement new approaches to CCS. And thank you for letting me speak here today.
Thank you very much. Any questions?
No, thank you. I apologize. When you have a child, you have to deal with things, right? Even when they don't have special needs. So, one of the things that I know, Dr. Block, you mentioned, I just want to double check on is that, again, obviously the proposal was to first roll it out in the code, the county organized health system. So, but obviously you said here in Los Angeles there's a two-plan model. But essentially, we would go from a system where you have a whole team of public health nurses, supervised by a pediatrician who's well-trained, who knows this, to potentially either they're all in one plan, they're split between two plans, and then a 10% subset for non-Medi-Cal patients. So we would fragment this coordinator. Right? Is that what you're saying?
As I understand the model, or as I understand the way it is likely to be implemented.
So we're actually moving from, because we talk about coordination, we're actually moving from less fragmentation to even greater fragmentation. I mean, I come from a county that's geographic managed care. We have multiple plans. We don't just have two plans, and San Diego's the same and so forth. Yes.
We actually have what amounts to several plans because each of the two plans has so-called plan partners who act as plans.
So in other words, and I realize you wouldn't have the answer to that, I guess one of the questions would be in those situations, who has the responsibility? Does the overall plan? Are they going to then subcontract this? Would they be allowed to subcontract this to individual groups and so forth? And how many different pieces are we going to end up with? I guess that's a potential issue, right?
Yes, my experience is that the biggest problems we have in dealing with our managed care partners are in those IPAs that have some apparent distance from the original MOUs and the original contract, and therefore sort of plead ignorance about some of the requirements that CCS, that the carve-out really called for.
Right. And then I guess the other question I have just to follow up is, as the medical director, whether, I don't know if you know, just looking at, for example, for Los Angeles County, because you talked about, now the plans would be the ones contracting and whether they'd contract or not. But the other thing that could happen is that you negotiate with one group, you contract with one group 1 year, next year you contract with a different group, you go back to the same group because they gave you a better deal the year after. But in terms of the current system, how is the provider stability? In other words, this continuity of care over time, is that something that in the current system is pretty stable, and be concerned that there might be instability in the future just because if you happen to stay with the same plan, you could find yourself with different groups from year to year?
Well, again, we're talking about, if you're talking about the carve-out, there is stability in the CCS networks, and because we authorize primary care related to the eligible condition for those kids with complex conditions, we have stability even in primary care for that part of our population.
Right.
It's hard for me to comment on the non-CCS primary care docs assigned by Medi-Cal, other than to say that they tend, other than those who are affiliated with major medical centers, and that's an exception that I wish we could generalize in some way, but those primary care docs who have been assigned by Medi-Cal are great and do the job well and so forth. But the ones who are non-pediatricians, non-board certified, non-panelable, which is the majority of primary care providers, I would say it's difficult for us to even assure coordination, communication with those physicians. So it's difficult for me to even know how stable that.
But you would say the current system, basically, you have a very stable network that people from year to year to year who aren't CCS aren't having to, unless they choose to do so, can actually stay with the same provider for years.
Again, I want to stress that this is the LA County perspective.
This is LA,
I know there are some parts of the state where there are a lot more board-certified pediatricians in taking part in the CCS or in managed care.
Okay.
So
yeah.
Dr. Yes. Yeah, I think that's a really important point about stability. And one of the major differences between CCS and the traditional Medi-Cal managed care plan is that CCS is a population-based program for these kids. And I think you did an excellent job of laying out the rarity of a number of these conditions. So you need a program that's really focused on that entire population, where the plans are necessarily focused on their members. And that's a very different perspective. So I think when CCS, you get a statewide provider network that is stable to the degree any provider network can be stable in California, whereas as we've seen from what happens with plan directories, that's whatever the opposite is of stable in this case. So I think that is a major concern for us, that we would lose the stability of that population-based program with that statewide network, provider network, if that medical case management function was given to plans which operate on it's a different model for a different population.
And certainly, I think we've had challenges with plan directories, and I know Senator Hernandez has been a statewide leader in trying to ensure that people have accuracy, because that's how people try to find providers. Maybe just one side comment is, as a CCS provider, I actually picked up a new CCS page. It took me about 2.5 hours just to do medication reconciliation because of the complexity of the patient's condition. Imagine that patient now has to find another primary care doctor every couple of years who would have to invest just that level of time to figure out what their medications are and what kind of payments the incentives are not to actually do that level of work. But thank you so much for your testimony.
Thank you. Let me thank all of you for being here. We're going to now move on to item number 5, physician, hospital, and health plan perspectives on the CCS program, the DHCS proposal, and the ideas for program improvements. We have Dr. Chinook, President of the California Children's Specialty Care Association, Professor and Chair of Pediatrics, Chief Medical Officer, Loma Linda University Children's Hospital. We have Ann Kuhns, President and CEO of California Children's Hospital Association. You heard earlier, out of order, Dr. Lewis, Han Pham, CCS Project Director, Health Plan of San Mateo, and Kathy Neal, RN, Chief Health Service Officer, Central California Alliance of Health. We can have you present in that order. What I can also ask, if you don't mind, if we can keep the comments germane and not repeat what has been said in prior testimonies. We're running way behind. We're supposed to be out of here in 15 minutes. So if we can just kind of make it a little bit more succinct, and anything new you can add, I would appreciate it. And thank you very much, and please proceed.
Sure. Thank you, Senator, and Senator Pan. Nice to be here. So if you don't mind, we've given you, or will give you, the prepared remarks, and I have been frantically using my yellow highlighter so I can try to be as succinct as possible. So as you said, I'm the president of the Children's Specialty Care Coalition, and also have functions at Loma Linda as the chair of pediatrics and the chief medical officer. The coalition was founded in 1998 to address the growing crisis in availability of pediatric subspecialty physicians. And today we represent 2,000 pediatric subspecialty physicians. So we're coming from a place of understanding this group of CCS patients. That's what we do. We do it every day. In my own practice, I am a panel provider, and I am a pediatric heart transplant specialist. So we really appreciate the opportunity to present today, and we also appreciate the department's willingness to engage a lot of stakeholders in trying to work through this. There are, as people have been saying, good stuff and not so good stuff about the way that the program works now. Let's talk about what works, and I just want to emphasize, and everybody else has done this, but it is related to the clinical standards for providers and special care centers. So let's just stipulate that and go on. Those things that our coalition believes could be improved would be the fact that there's inadequate mental health coordination and access, particularly funding for special care centers to be able to adequately coordinate and provide mental health services for CCS children. There is less than optimal communication coordination between specialty care providers and primary care providers. There is not a sufficient tiering of children based on complexity and need for enhanced care management. There's a lack of resources available to support creating and developing standards for medical homes. And I think if we move to a whole child model, how we set up medical homes for these kids and the standards for them is going to be critical. It can't just be a local pediatrician trying to provide this in their practice without additional support. That won't work. A big recurring theme is the lack of substantive and data regarding quality and outcomes to demonstrate the program effectiveness. And it is going back to the if it's not broke, don't fix it, even though there are challenges in what we do. So we are glad that the department is including a phased-in approach. This can't be done in a big bang fashion. We believe the phasing may be aggressive, but it's nice to see that there is a phased-in approach. The whole child proposal is well intended, but there is currently no evidence to substantiate that this model care will provide care on par or better. The Coalition's priority is to ensure CCS eligible children have uninterrupted access to quality pediatric specialists and the special care teams. So it's unclear how the plans will be monitored in terms of adherence to CCS standards and adequacy of networks. The other challenge for me as a department chair of pediatrics is recruiting and retaining quality subspecialty faculty. And any conversation related to a redesign has to include some mechanism of supporting financially the centers in a way that allows us to recruit and retain the best faculty possible. Regarding the shift of utilization review and case management from the county to the plans, the Coalition has significant concerns in the shift of locus of control for these functions. And if the plans are responsible, there must be an expedited approval and or appeal process. And consideration should be given to distinguishing a benefits design for CCS designated patients. If the benefits design was unique to these kids, that might actually alleviate some of the concerns. Related to the medical rate for carved-in children, we believe that CCS kids need to remain unique, which should be reflected in the way that the plans are paid. We're not big fans of a blended rate model because these children tend to move back and forth and the funding should follow the child. So in closing, I'd like to thank the Senate Health Committee for convening this hearing and for the attention you're paying to the CCS program. It's vitally important that all of our voices are heard. And I think it's helpful that our representatives' voices are heard as well. CCS has been a highly effective program, and the Coalition recognizes there's room for improvement. We're glad to continue to participate in the stakeholder advisory process and future legislative hearings. We believe there's a shared commitment from stakeholders, the legislature, and the department to provide a quality system of care that meets the needs of the whole child with special health care needs. Thank you.
Thank you.
Good afternoon. I'm Ann Coons, President and CEO of the California Children's Hospital Association. We represent the 8 freestanding, not-for-profit children's hospitals in California. On behalf of our members, thank you for the opportunity to talk with you today about the CCS program. You've asked us to address several specific questions related to the program and the Department of Healthcare Services proposal to carve CCS into Medi-Cal managed care. Before I address those questions, however, I want to very briefly give you some context about children's hospitals and the CCS program. California's children's hospitals provide the backbone of pediatric specialty care in California and are major providers of care to the CCS population. Children's hospitals provide 68% of all CCS inpatient care and operate a preponderance of CCS-approved special care centers, which are the outpatient and inpatient centers that are designed to treat holistically the complex social, emotional, medical, and support needs of CCS children with medical conditions like cystic fibrosis, hemophilia, sickle cell, cerebral palsy, and cancer. Children's hospitals tend to treat children with the most complex medical needs, including children who are transferred to us from community hospitals. We're deeply committed to caring for all children with complex healthcare needs, including those children eligible for the CCS program. One of the questions you asked is what works well about the program. From our perspective, there are 2 aspects of the CCS program that work particularly well for children with special healthcare needs. First, as many of the previous speakers have mentioned, the program has developed rigorous clinical standards that providers must meet in order to treat CCS-covered children. I'm not going to spend a lot of time talking about that since it's been discussed quite a bit, but there is, I will say that there is actual research that's been done to indicate that, in general, providers that treat more, I'm not sure Dr. Pan knows, treat more and are qualified to treat more children tend to have better outcomes. So there's a lot of evidence in that area. The second aspect of the CCS program that we believe works well is the use of CCS-specific utilization review and care management procedures and staff to ensure that children get the right care at the right time. Children are not little adults, and children with CCS conditions have particularly unique health and support needs that are unlike the needs of other children. County and state CCS staff have a tremendous amount of experience with the particular needs of the CCS population, as we've just heard from the previous panel, as well as knowledge about the appropriate medical expertise that is best suited to a particular child's needs, whether that expertise is available locally, regionally, or elsewhere in the state. It's important to point out in this respect that surveys indicate that parents of children in the CCS program are very satisfied with this aspect of the program. It's also important to note that the expertise provided by state and county CCS staff would be difficult, if not impossible, to recreate on a health plan by health plan basis. For this reason, we would recommend that county and state CCS staff continue to perform the care management and utilization review functions under any transition to managed care. You'd also asked whether Medi-Cal managed care plans should receive a separate rate for CCS children, or whether the funds for CCS children should be blended into a single rate that the plan would receive for all children it covers, both CCS and non-CCS. We believe very strongly that plans must receive a separate special CCS rate for the CCS children they cover. Without this rate, plans would have a disincentive to identify children as CCS eligible. Providing a special CCS rate ensures that plans will seek to appropriately serve CCS eligible children in order to obtain the enhanced rate. That rate can also be tied directly to the use of specific standards and requirements. In addition to the recommendations I've just provided, we would recommend that the legislature consider the following 4 improvements to the department's proposal. First, we'd recommend a phased-in implementation of the CCS carve-in, starting with county organized health system counties and only moving to 2-plan model counties after an evaluation has been completed. We believe that carving CCS into 2-plan and geographic managed care plan counties poses considerably more risk to the pediatric specialty care network than county organized health system counties. For example, as Dr. Block had mentioned earlier, in Los Angeles, the Medi-Cal managed care health plans delegate risk to subcontracted plans who frequently further delegate risk to large medical groups. This complex arrangement reduces the funding available for providing actual medical care and would make contracting arrangements very burdensome for a large pediatric specialty care provider like Children's Hospital Los Angeles. Second, we'd recommend requiring, as other people have mentioned, stringent reporting requirements specific to the CCS population so that policymakers will be able to determine whether the promise of improvement is being realized. For example, one of the goals of the whole child model is to maintain quality and access to care. Thus, it seems reasonable that plans should be required to report annually on access to special care centers as well as primary care and be held accountable when access standards are not met. In this respect, I'd just like to add that it's been, I think it's over 8 years and possibly as long as 25 years that counties have been required to report on certain metrics about performance in the CCS program, and the state hasn't done anything with those metrics yet. So it's really critical that whatever we're collecting we actually look at and we evaluate and we establish as a benchmark before we actually begin to move forward. Third, we'd recommend that everyone who's enrolled, wherever this carve-in model is incorporated, that children have access to independent medical review specifically, regardless of whether or not, we think it would be preferable that all plans have Knox-Keene license. We don't think the department's process, although it may be a good process, really can mirror the independent medical review and the expertise provided through the independent medical review process, so we feel very strongly about that, particularly given the medical complexity of CCS children. Fourth, we would recommend requiring a continuity of care, adding a continuity of care requirement for the length of the CCS condition. The department's proposing just 12 months. Many children in the CCS program have complex lifelong conditions like sickle cell or cystic fibrosis, and we believe it would be reasonable to require continuity of care protections that extend for the life of the condition rather than arbitrarily limiting this protection to 12 months. These are the improvements that would be necessary at a minimum, we think, to allow a CCS carve-in to proceed. On the other hand, we would agree that the department's proposal has the potential to address one particular shortcoming of the current CCS program, and that's the lack of coordination between a child's primary care, which is frequently the domain of the child's Medi-Cal managed care plan, and that child's specialty care, which is arranged and paid for by the CCS program. This current arrangement gives rise to disputes between Medi-Cal managed care plans and the CCS program over which program is responsible for services. This can leave the family and the medical provider stuck in the middle. A CCS carve-in could resolve these sorts of problems. In closing, I'd like to express our appreciation to you, Senator Pan, Assemblyman Bonta, and the many other legislative champions who throughout the year have helped to protect this important program. It was only with your support that we were able to obtain passage of AB 187, which extended the CCS carve-out for another year. I'd also like to take this opportunity to express our appreciation to the governor for signing the bill. The governor stated that he did so as an expression of good faith towards all of those who must work together to thoughtfully, responsibly, and appropriately transform this important healthcare program. We are here in that spirit, and we appreciate the ability to provide our input today. Thank you.
Thank you.
Good afternoon. Good afternoon. My name is Han Pham, and I am the CCS Demonstration Project Director at Health Plan of San Mateo. On behalf of Health Plan of San Mateo, I'd like to thank you for the opportunity to speak about our experiences with the CCS program. Health Plan of San Mateo, or HPSM, was founded in 1987 as a county-organized health system that could provide a community solution to local healthcare concerns. The San Mateo Health Commission created Health Plan of San Mateo to provide access to high-quality and coordinated healthcare for Medi-Cal patients. Today, we serve over 140,000 low-income patients. HPSM supports the Department of Healthcare Services' proposed whole child model. As a part of the CCS demonstration project, HPSM has implemented many aspects of the whole child model and has found that the whole child model provides a better experience for patients, families, and providers. HPSM's CCS demonstration project came about because of the difficulties our CCS patients, families, and providers were experiencing. In 2012, HPSM and the County of San Mateo Health System conducted focus groups with CCS families to understand their concerns with the healthcare system. We found that CCS families were confused about who to turn to for help and had complaints about pharmacy services. Their confusion about who to turn to for help came from the fact that CCS care is siloed from all other health care. This silo occurs because CCS care coordination and utilization management is provided by the county's CCS staff, while care coordination and utilization management for all other healthcare needs are provided by the Medi-Cal program. This makes it difficult for patients to understand who they should contact when they need help for their healthcare. This fragmented system is especially difficult and confusing for our non-English speaking families who do not have the language skills to navigate the system. In response to this need, HPSM applied for the CCS demonstration project with support from the County of San Mateo Health System, community providers, and families. HPSM began a CCS demonstration project in April 2013. The goal of our CCS demonstration project is to build a healthcare system centered around the patient. We call this the whole child model. The whole child model entrusts all of the patient's care to one entity that can focus on all of the patient's needs and brings all of the care coordination and utilization responsibilities under one organization. HPSM works very closely with the county CCS program to ensure that their CCS expertise is integrated into our project through co-location of the CCS staff at HPSM and by subcontracting with the county CCS program to provide care coordination and utilization management to our CCS patients. We also actively involve our CCS patients, families, and community providers in this project through our CCS Parent Liaison, our Family Subcommittee, our Youth Advisory Committee, and the Demonstration Project Advisory Committee, which is comprised of community health providers, local community organizations, and families. We have found that our CCS demonstration project has improved patient, family, and provider satisfaction. For our patients and families, the whole child model has helped them in the following ways. One entity now does all the patient's care coordination and utilization management. If the patient has any questions about their care, then they can call just one place and they can get help. This has reduced confusion for our patients and families. Our patients now receive more generous benefits. HPSM provides them with whichever benefits are more generous to the patient, either Medi-Cal or CCS. In addition, HPSM has expanded the pharmacy formulary for CCS patients so that it is easier for them to get their medications. We have also streamlined access to incontinence supplies and provide supplies that are not part of the traditional CCS formulary, such as gloves and wipes. We have also worked to provide access to mental and behavioral health services for our CCS patients by creating a referral pathway for our care coordinators and training them on how to activate patients to access these services. To enhance care coordination, we conduct comprehensive assessments on each patient so that the care coordinator understands the patient's healthcare needs. We have also begun to work on the transition process for patients who age out of CCS. The CCS care coordinators and the health plan care coordinators work closely together to ensure that the patient's needs are addressed before, during, and after the transition process. Lastly, patients have access to health plan's grievances and appeals process. Health plan has a formal grievance process to track and monitor grievances for any quality or access problems. This grievance process is not part of the traditional CCS model. Whole child patients also have a longer time frame to appeal denials through a health plan, which provides 90 days to appeal versus 30 days for CCS. For our providers, the whole child model has helped them because they only have to contact one entity for any questions about care coordination, authorizations, or claims. We are also piloting a process to reduce the number of authorizations providers need to get before they are paid for the care they provide. Currently, the CCS program requires that any care requires an authorization. We find that this reduces paperwork for providers and gives them more time to focus on patient care. We have much more work planned for our whole child model. In the future, we will be working on expanding transition services, redesigning our care coordination program, implementing a medical home model, and much more. The work that we have done and that we plan to do is possible because of the CCS demonstration project. This project gives us the flexibility to create local solutions to the problems faced by our CCS patients, families, and providers. I would also like to address some concerns about health plans that I have heard today. I've heard that health plans make financial decisions rather than clinical decisions. This is not the case. We base our healthcare decisions on whether or not the requested care is medically necessary for the patient, and if so, whether the provider is clinically able to provide that needed care. Because of this, we regularly send patients to providers that are outside of our network, the county, and even the state, in order to provide them with appropriate care. For example, last year we flew a patient to Philadelphia because that was the only provider in the entire country that could provide them with that care. We are also regularly audited by DHCS, DMHC, and CMS to ensure that our decisions are made based upon clinical criteria. And most important of all, it's the right thing to do. So in closing, we look forward to continuing to serve our CCS patients, families, and providers through the whole child model. And we thank the committee for the opportunity to speak about our work. Thank you.
Thank you.
Thank you. I'm Kathy Neal. I'm a doctoral prepared registered nurse. I'm also the Chief of Health Services for Central California Alliance for Health. We are a county-operated health system that covers 3 counties of Santa Cruz County, Monterey County, and Merced County. We have a total of about 336,000 members. Of those 336,000 members, 6,000 members roughly have CCS conditions, and 4,750 of those members are open CCS cases at this time, which are managed by our 3 county public health systems. I also wanted to speak about some information that I heard today related to the main advantage that the Alliance sees and would support whole person care is because of the increased coordination of care, which would increase communication with the primary care physician and other caregivers, as well as reduce the duplication of requests and the number of denials that go back and forth between the systems about whose financial responsibility it is to cover certain conditions. The UM nurses, the population management nurses, the care management nurses at the Alliance are not aware of the financial arrangements, and so they are not making financial decisions when they make evidence-based decisions based on medical criteria that we use, national criteria. So I feel very strongly that we're not making financial decisions at the Alliance, that these are truly benefits that benefit the care of our members. Additionally, I wanted to speak about how do we know that we're doing the right thing? And from a managed care perspective, our quality measures are measured and reported on a quarterly basis through our work plan, which measures such things as ED visits, avoidable ED visits, readmission rates. We specifically track DME delivery and wheelchair requests, as well as the number of face-to-face and complex care management patients that we manage. And we do that by population groups. Because we know who our CCS population is, it would be possible to monitor those quality indicators through the work plan for that population as well. Additionally, through our quality improvement work plan, which is reported quarterly up to our board, not only are our preventative care measures through HEDIS measured, but also we do member and provider satisfaction, readmission performance improvement project, as well as asthma performance improvement project focused on reducing admissions and ED visits and increasing educational needs for those asthmatic patients. So there are measures already in place that we could measure by population, because the population is large enough to do that by, that would demonstrate what the effects of managing those cases in managed care are. Thank you.
Thank you. Any questions?
So for Well, I want to thank you all for your testimony. Just a question for the two, for Ms. Pham and Ms. Neal. So when the health plan, you negotiate a rate with the plan, who pays if the expenses that year exceed what you're getting paid from DHCS? Who pays for that? The county, your county organized health system, the county does? Where does the money come from when you exceed the negotiated, because you have a negotiated rate, capitated rate from the state. There could be variation in costs. You have more hospitalizations from CCS patients, and we know that they're the most expensive patients and among the kids. Who pays for that if you happen to fall short in payments that year?
I can answer that question for you.
Yeah.
So from a perspective of, because it's a blended rate and we look at our budget overall, not by population based, while we may internally track where we are in a population base according to what we budgeted or our rates were reimbursed, we look at the overall big picture of all of the rates and all of what the benefit is to that. Additionally, the health plans have some reserves that we do dip into to pay for these cases that fall out of what you might consider what we've normally been reimbursed for on an annual basis. Once those charges get into our base rates, which Ms. Kent briefly talked about earlier today, then we have that benefit for future years after that first year. So we're not continually dipping into our reserves for the same benefit.
And I know that Knox Keene plans have reserve requirements. What are the reserve requirements? Do you have reserve requirements for Medi-Cal?
There are reserve requirements. I can't speak to what that is because that's not my area of expertise, but there are requirements.
Okay. And then the other question I have is that I know I've seen, because we talked about patient satisfaction, this one's specific to CCS, but I've seen CAPS as a standardized plan for patient satisfaction for health plans overall. It's not specific to Medicaid. I've seen that Medi-Cal plans, again, there's some exceptions, have generally performed very poorly on those. And I have to admit I'm concerned about that. Now, this is not for CCS specifically, but sort of similarly to my concern about their performance on cancer outcomes that also has been published. I just want to be very cautious about this because these are the people who are going to have the most interaction, and the fact that we have, most plans are 4 or 5 stars, and we have a lot of 1 and 2 star health plans in the Medi-Cal system is very concerning to me as well. Thank you.
I think I would be remiss if I didn't state that these are county organized health systems, so they're separate from like any type of commercial plan. So I think in general, the county organized health systems, the satisfaction for CAPS is actually much higher than it is for
I've
the
seen
Medi-Cal
the CAPS
managed
data,
care.
so it is very concerning. So again, there are exceptions. I think San Mateo may be one of them, but unfortunately, we're talking about a system for the whole state, not just for San Mateo County.
Yeah. I just mentioned this because the department's proposal is specifically for county organized health systems to begin
Right.
with.
Well, I'm talking about, talking about health plans across the state who are in Medi-Cal. So that includes county organized health systems. I guess the other question is that I understand San Mateo, that UCLA is doing an evaluation of that. So as an independent evaluator, do you know when the results of that evaluation will come out? Because we have not seen it.
Yeah, that's the department's evaluation that they had UCLA do. And I know that they have put it on hold, the department had.
Okay, so I think it's very important we have an independent evaluation. I realize you have a lot of wonderful things to say. I would say that some of that comes from, I agree with you. We can get everybody in one place so that families don't have 2 places to go, but there's multiple ways of doing that, not just folding everyone into a health plan. So, I appreciate that that's what you've been able to accomplish, but that's not the only way to do it. But I think it's a good idea to try to get, so that families don't have to have so many places to navigate.
And we completely agree about the evaluation importance, and we're actually going to fund our own evaluation since the department put theirs on hold.
Okay, which is of course is concerning to me because we want an independent evaluation.
Yeah,
this
we
is the
thought
one
that
pilot
would be
we
great
got,
too.
and they put that on hold. So yes.
Yeah.
I was just going to add that it's my understanding that there had been a telephonic survey or some sort of survey of like 300 parents of CCS kids at some point, and we had asked for if we could get the results of that, just because that would be an indication specific to this particular pilot as to what parents were thinking about it.
Okay, so I certainly hope that information can be made public as well, because again, we want independent evaluation of what we're doing, because hopefully we're all committed to being sure we got the right outcomes. So, thank you.
Thank you. Let me thank everyone for being here and for their time, and we will now move on to item number 6, response to testimony by Department of Healthcare Service. I'll ask Director Kent to come up and see if she'd like to make any closing remarks or any comments. Here's 2 questions.
So in closing, I'm going to be brief. I have a flight that I cannot miss, so I am probably going to need to leave in about 15 minutes. But I just wanted to say, again, consistent with the comments that we heard today, is that we have a lot of work to do. We have a lot of different pieces of this program that are both challenging and complex. We're committed to sitting down and working through it. I really appreciated, especially the Children's Specialty Care Coalition. They have been really forthcoming partners in the discussions that we've had, and had, very frank and candid conversations with them about what concerns them most. And so I think that, we have heard from a lot of different entities and partners that we work with and contract with and serve multiple constituencies with, that we will continue to put our best foot forward in how we do this in a thoughtful way. And so with that, there's just more conversations to be had, and we're committed to doing that in a thoughtful and consistent manner, both with the legislature and others. So thank you.
Thank you. Any comments?
So I appreciate the governor signing Senator Mbanta's bill and his expression that in terms of being sure we have a good faith effort. I hope that we don't just try to rush something. A year is a short amount of time, was mentioned. I think hopefully we all have the same goal, and that's what we're trying to do. We should do it on an evidence-based piece. One thing because at the end of my questions to you earlier, you had made mention in the legislation. So I had asked a question about being sure that we were transparent with contracts, and also with being able to be sure that, see if the department's open to having language specifying the types of evaluation processes and evaluation we would have for the plans. So I just want more specifically comment on that. And the bill sort of said CCS related, boilerplate language, but I want something more specific than that, that gets more to, again, for greater transparency about what the obligations of the plans will be in any sort of situation, to be sure we're going to be able to evaluate the outcomes and that there's accountability. So I guess I'll ask you again, is there a commitment to that, and not just boilerplate language, but actually having transparency, the actual terms, and both specialty and primary care, when we say CCS, it's a little vague about what that piece means, that involves the CCS patients, and as well as more substantive language regarding required evaluations, mandated evaluations with penalties attached if the evaluations are not performed in any sort of legislation.
Okay, so boilerplate contract language means it's the contract. So we're happy to share that with you. So if you don't like that language, you can suggest an amendment to it.
But having the actual language is fine.
Yeah, the language will be that's what it is.
Yep.
And then we specify what the evaluation looks like on page 5 in terms of what we commit to doing before further counties, are subject to a carve-in proposal. If you have language around that you'd like to propose, then you're certainly, A, we'd love to hear it, and B, I don't know that we would agree as an administration to penalties on ourselves, but I know that we have funding for the CCS evaluation as it pertains to San Mateo, according to my staff, that we have included in this year to do the evaluation. I think we had put it off because we were waiting to see what happened with the renewal of the 1115 waiver. So we will evaluate it, as well as what we will commit to evaluating as the language is there.
Okay. Well, certainly, I think it's important. We've unfortunately seen a few examples where, again, it was before your time, but there were commitments made by the department that weren't followed through, and there should be some consequences to that. I mean, so we can talk about what they should be, but I think that we need to be sure commitments are followed through.
Great.
Thank you.
Thank you.
Okay, I'd like to just thank you for your time. Wish you a safe flight back, and
I'm not staying.
I got it loud and clear. And I will definitely follow up with you, and my staff will follow up with you, and look forward to working with you as we move this forward. Anyway, we're going to now move on to item number 8, public comment. We have a microphone up here.
Hello, thank you for having this and for coming to Los Angeles. I've been on buses to Sacramento twice, And I've taken recovery from those trips for hours, and it took a few days to recover from those trips, so I really appreciate you being here. I have concerns. My name is Deborah Greenspan. I'm a member of the American Nurses Association, but I'm also here primarily to let you know that parents have concerns. Parents that have not had a diagnosis that meets the criteria, and I wanted to relay some things regarding that. But before I do, I wanted to ask, what is the transparency? What is the feedback and the parent and guardian engagement? Will you have a website? Will you have an email address that you can let us know now? There are parents that are watching live stream, so if you could please provide that, that would be wonderful.
The information is posted on the committee website, and the hearing will be posted on the committee's
Yeah, so
website.
all of this will be posted on the Senate website. If you want, we can follow up with you. I can have my staff give you that link, and it is public. It's available to the public.
So I'm asking not just that you give us access to this, which is wonderful, but also that we have ability to have ongoing stakeholder communication with legislators. I wanted to relay two stories. One was when my children were in elementary school. I overheard a parent telling me why she wasn't going to allow her son, who is twice exceptional, who was gifted with ADHD, to go into the gifted program because she had so much stress from when her younger child was not diagnosed early, and the educational system and social services, speaking of lack of expertise, accused her of, and her husband, of abusing her child who wasn't thriving. So I want you to understand what it does to the whole family system, and that the lack of expertise is not just in healthcare, but it goes wherever the child goes is where that expertise needs to be. And I understand these are rare conditions. We need to get better at what we're doing to families. So in high school, when my child had an IEP and the teacher didn't want to go to it, I got a call from social services because I was being accused of Munchausen by proxy. Why did I know so much? They didn't take into consideration I'm a nurse. I'm a scientist, investigator, scientist by background. I look into things, I research things. And it was very hurtful. It was also very timely. They did that on a Friday before the Monday IEP. So I understand there was a time coincidence there. But the coincidence worked in my favor because I also had the records from my child's providers in a patchwork system because my child had also a rare condition, but not eligible for this system. So I'm making a plea for you to understand that these stresses that happen to families happen to more than the patient that's there in front of the provider. And we need better services throughout California. Thank you very much.
Thank you. Next.
Thank you. My name is Michelle Kim. I'm the Executive Director of the Hemophilia Foundation of Southern California. I actually come here today not as the director of the Hemophilia Foundation, but it's because I told my daughter that I would come on her behalf. She's in her 4th week in the ICU at Miller's Hospital. I'm so sorry. This is so unprofessional. She sees over 12 specialists on a regular basis, and I'm deeply concerned about this CCS redesign program. She actually uses CCS as a secondary insurance, and for us, it's a huge financial lifesaver. I want to add one thing that was brought up today that deeply concerned me, and it was a statement that Jennifer had made when she said that the plan will remove the coordination of care burden from the parents. I have another son who's 20. He has severe hemophilia. I tried to apply for Medi-Cal for him several years ago. On the same day, I received 2 letters from Medi-Cal. One, I'm sorry, your son is denied Medi-Cal benefits. The next letter I opened up, and woohoo, there was a Medi-Cal card in the letter, and it said, welcome to Medi-Cal. I was completely confused. Are we in or are we out? I called Medi-Cal, and there is no person to talk to. It's just a central receiving phone number, and you leave your name and your information on the recording. I've yet to receive a phone call. The only reason why I know that he was actually denied officially is because I went to his hemophilia treatment center. They ran the benefits. They said, you don't have it. So I assumed the card, he has a card, he has a number, it's not activated. I don't understand how that kind of group is going to take over and manage the administrative care. On the other hand, this morning I left a message with my CCS coordinator, Myrna Coe. She's wonderful, she's awesome. I did get a letter a couple weeks ago saying that the CCS would not be covering her stay based on the emergency room notes. Her diagnoses are completely changed since then. But when you're going through something that I'm going through right now, you do not want to worry about whether you're going to get zonked with a $500,000 bill. You just want to fight to keep your child alive. And so I appreciate so much that I have Myrna that I can call. I have her direct number. She's already tried to call me back several times, but I'm like, oh, I'm in the CCS hearing. So those 2 things that I want to just share with you. And then also just the person who previously testified, if you could really consider the stakeholders, the parents who go through these kind of very difficult situations who have CCS, if you could really consider including them in all of your discussions and your negotiations, I really appreciate that as well. Thank you.
Thank you.
Good afternoon. My name is Amy Lambert, and I am an assistant superintendent for special education for the Foothill SELPA, Special Education Local Plan Area, the SELPA. And I'm here today on behalf of 136 state SELPA administrators of California. And I just want to applaud you for the attention that you've been able to give to this matter for over 3.5 hours. So I'd prepared more comments, but I'll just be very brief. SELPA's been attending the CCS stakeholder meetings convened by the Department of Healthcare Services throughout the state because we want to call attention to some conflicting responsibilities between educational agencies and CCS under the program that's really become increasingly difficult to manage and has caused confusion for students and their families. We want the legislators to be aware of these issues as changes to the CCS program are under consideration. You know, in this current landscape that we're operating in, there is currently opposing legal decisions regarding the roles and responsibilities of education entities and CCS. We're not sure if you're aware of all that, but we think in this time period right now, it's an appropriate time to reevaluate the relationship between CCS and schools and provide much needed clarification regarding these appropriate roles and responsibilities for each of the various entities. So we will be providing you with some written input and some topics to share with you in the next coming weeks, and we look forward to continuing the dialogue with you. Thank you.
Thank you.
Hello, I'm Dr. Mona Patel. I'm a general pediatrician here in Los Angeles. I'm a board member for the American Academy of Pediatrics, and I'm also the director of a very large community-based FQHC within Children's Hospital Los Angeles, and I'm the medical director of our patient-centered medical home for children with special health care needs. Of our 80,000 clinic visits last year, about 40% are children with complex care, greater than 5,000 patients. And Senator Pan and Hernandez, I wanted to thank you so much for being supportive, and I echo everything you said, Dr. Pan, about all of the importance in waiting. Looking at data, we are looking at the same data drivers and quality information, and soon, hopefully by the end of this year, we'll have that published. So any help that we can provide, that would be great.
Thank you. Anyone else? Yes, please come and state your name.
My name is Adrienne Belcours, and I'm just a mom. I am fourth-generation mother in my family to have a child born with sickle cell disease. And how can I say this? I was born in California. My mom was born in California. I guess we're third-generation Californians too, which is kind of weird. But I want to thank you. I've had a long journey. I've lived with sickle cell all my life. It was my elder brother who had sickle cell disease. And my mom was very, very strong, a lot like these moms that I've heard testify, and was very into us being responsible and looking out for my brother and her looking out, and for us being educated about the disease. And we had some pitfalls. All of us kids were tested, and I was told I didn't have the trait. I was told that African Americans were the only ones who had sickle cell. I married a Cuban. We had this very beautiful baby who was diagnosed with sickle cell. And I started my journey as a mother, strongly, strongly believing that I would be the last mother in my family, the last generation of mothers to have a child to suffer. And thanks to California and the work they're doing with stem cell, that really seems to be a reality. But my journey did start off with CCS, helping me with my daughter. And I want to say that the pediatricians in California, along with CCS and what the legislation has done in providing funding and oversight, has been tremendous. All those children that started off with my daughter, when they were told you wouldn't be 1, you wouldn't be 2, you wouldn't be 3, my daughter's now in her 30s. And I just wanted to say thank you. And it's so important what you're doing, because if you don't do this, nobody else will. If you don't provide the oversight, if you don't provide the funding, there are 11,000 people in California with sickle cell disease, and that's not a lot. I can't tell you how many people I've talked to, and they've been said to us, oh, that's not a lot. But given the life of that struggle and how it affects everything and anything that we're able to do, it is tremendous. So I want to say thank you. I want to thank all of you who stayed all day for this meeting. Again, my daughter's too old for CCS, but I just wanted you to know that it's great that you're here and that you're really, really paying attention, because we are seeing a lot complaining. We are seeing a lot in tears. And we see a lot of heroes, and we don't often get to say thank you. So I wanted to say thank you to all of you who are here, and thank you for letting me speak.
Thank you. Any other public comment? Seeing none, I'd like to thank all the presenters. I'd like to thank Director Kent, members who showed up, and with that, we'll adjourn today's meeting. Thank you.